I'm sorry. I welcome you all and wish you all a very good morning. On behalf of the organizers, I welcome you today to the workshop of Understanding Transcranial Direct Current Stimulation from Basics to Application, being held here at Lucknow. This program is a joint initiative of the Global Psychiatric Association and Indian Psychiatric Society UP State Branch and brings us together a distinguished panel of experts in neuromodulation and neuropsychiatry. We are privileged to have here with us our respected speakers and chairpersons who will guide us through the theoretical foundation, evidence based, and practical applications of tDCS across the day. To begin, I invite our Masters of Ceremony, Drs. Anjali and Khushbu, to take over and guide through the proceedings.
A very warm and pleasant good morning to the respected chairperson, our esteemed senior faculty members, and dear participants. It is indeed a matter of great honor and privilege for me to stand before you today and extend a heartfelt welcome to this workshop on understanding transcranial direct current stimulation from basics to application. Your gracious presence truly adds immense value and charm to this event. Today's workshop beautifully brings into focus the evolving and promising field of neuromodulation, which is opening new horizons in psychiatric care. Now, I would like to invite Professor Vivek Agrawal sir to kindly bless and inaugurate the session. Vivek sir is a renowned psychiatrist and the head of psychiatry department, KGMU Lucknow, and expertise in child and adolescent psychiatry, and vice president of Indian Association of Child and Adolescent Mental Health.
Thank you. Very warm good morning to all of you. Dignitaries present online, offline, my colleagues, dear students. I welcome you all on behalf of Department of Psychiatry, KGMU Lucknow. The field of neuromodulation is very rapidly evolving in the psychiatry. And it is not only applicable to psychiatry, but its application is much beyond psychiatry. Neurology, neurosurgery. So it's time that we learn neuromodulation. Why? Because it is much more acceptable to the patients. It's a non-invasive procedures, and now in a short time it will be tailor-made to the application at home by the patients themselves, or even it can be remotely operated like robotic surgery. These machines can be remotely operated to be delivered at home. So it is going to be much more acceptable and convenient way of delivering the therapies. So in our department, we began long time back with a very basic machine of RTMS. And now we have a very good lab of neuromodulation thanks to initiative of Dr. Sujit. So I congratulate the team to organizing this workshop on transcranial direct current stimulation, which is much in use in our department. And it's heartening to know that even international speakers are there to guide us. So I wish the conference all the success. Thank you.
Thank you, sir, for your guidance and valuable time. Now I would request Professor UC Garg, sir, for the inauguration session, but Dr. Joshi Garg sir will not be present today. However, he has conveyed his best and warm wishes for the success of workshop. I would next like to request Dr. Anurag Verma sir. Anurag sir is a renowned psychiatrist and Honorable General Secretary of Association of Clinical Psychiatry, Uttar Pradesh. Sir, we would request you to guide us about today's discussion.
Yeah. Good morning, everyone. I'm also, it's a privilege for me to be here among the stalwarts, Professor Reinhardt, Professor Vivek Agarwal. Then we are going to have the privilege to listen to Dr. Adarsh Tripathi and Professor Sujit Kar and numerous other people. As Professor Agarwal rightly said, that it is very exciting times and it's time that we psychiatrists embrace this new technology of tDCS, learn and not just treat illnesses, but explore the cognitive benefits and enhancements we can do with tDCS. So this conference, I'm sure, is going to be go to a long way in enhancing and increasing our learning towards this exciting new technology. I wish all the organizers uh, hearty congratulations and this deliberation a very, very big success. Thank you.
Thank you, sir. Now I would request Professor Rena Nguyen sir, a renowned psychiatrist at Germany. Sir is known for his work on functional neuroimaging, genetics, epidemiological studies, and clinical trials for mental disorders. A part of German Research Foundation and a recipient of multiple clinical excellence awards. Sir, please brief us about today's workshop.
Yeah, my name is Hoyn. I'm a consultant psychiatrist, and we are proud from the Global Psychiatric Association to support this symposium. The Global Psychiatric Association has the vision to bring knowledge from all over the world back to all over the world, and I hope that this workshop will be successful today. But we also would like to mention that we will record this meeting and we will make it available to other people. I'm really interested and excited about this new technique. I think we recently had a symposium about transcranial magnetic stimulation, and I think this is a very exciting addition. The Global Psychiatric Association has a journal, Global Psychiatry Archives, and Professor Sujit Kar is editor-in-chief of that, and I'm quite proud to support and be part of this meeting. Thank you.
Thank you so much, sir. Now I would like to request Professor Adarsh Tripathi, sir. Sir is a renowned psychiatrist and honorable treasurer of Association Clinical Psychiatry, Uttar Pradesh, and former professor, Department of Psychiatry, KGMU. We welcome you, sir, and brief us regarding this workshop.
Thank you very much, respected seniors and my dear colleagues. It's my proud privilege to be here in this workshop on tDCS. We all know that the newer modulations of brain stimulations are not only adding new methods for treatment in psychiatry, but they are also marking a transition in the way we think about psychiatric disorders. Psychiatric disorders understanding and treatment has evolved from asylum-based care to psychopharmacology to the circuit-based modulations, which we are attempting via newer modes of neuromodulation. In this series, tDCS is one of the important strategy for neuromodulation, and its use
its efficacy in certain different kind of clinical situations, as well as its utility in various variety of clinical scenarios, including home-based care, is likely to make this treatment strategy a useful armamentarium in our available treatment options. So I welcome again all of you in this workshop, and I hope that we all will learn something new and will be able to utilize this technique in much better way in our clinical population. Thank you very much.
Now I would request Professor Sujit Kumar Kar, a renowned psychiatrist at KGMU Lucknow, with special areas of interest in neuromodulation, non-invasive brain stimulation, and suicide prevention. We request you, sir, to kindly guide us regarding today's workshop.
Thank you so much, Dr. Khushbu. Good morning, everyone. It's a proud moment for me to organize this workshop with the help of Global Psychiatric Association and Indian Psychiatric UP State Branch, and in collaboration with the Department of Psychiatry, King George Medical University. It is a long planned idea that we'll be conducting some series of workshops on different types of neuromodulation. So initially we started neuromodulation, which is restricted to only psychiatric disorders. But we are fortunate that we had a good collaborator like Professor P.K. Sharma, who is a former professor in the Department of Neurology. He used to refer a series of cases with a lot of neurological morbidities like refractory epilepsy, patients with different movement disorders, Parkinson's disease. And we tried using tDCS in a variety of neurological conditions. We found some remarkable improvement, at least in some of the patients. It opens the window that tDCS is not limited to psychiatric disorders. It can be used in a variety of other settings where it has a potential role to play. In this workshop, this is more of a sensitization workshop where we'll be focusing more on overview of neuromodulation, followed by more focus on transcranial direct current stimulation, how it works, mechanism, and electrical parameter related things. Subsequently, followed by the last theoretical session that is on the different protocols and practical application of tDCS in neurological conditions and psychiatric disorders. This will be the pre-lunch session where we'll be having both online and offline participation. Following the lunch, there will be hands-on training, which will be more of an offline. So online session is only limited to the first 3 hours where we'll be having 3 lectures on the theoretical aspect of transcranial direct current stimulation. So this is the agenda for today's program. I hope you'll enjoy this program very well. So thank you so much. So I'm handing over to Dr. Khushbu and Dr. Anjali to carry out with the further proceedings of the sessions. Thank you.
Thank you, sir, for your valuable information and guidance. Thank you all the respected speakers for this information. We now begin the scientific proceeding. I request the respected chairperson, Professor Vivek Agrawal, sir, Head of Psychiatry Department with expertise in child and adolescent psychiatry, and Dr. Amit Singh, sir, Associate Professor in Department of Psychiatry, KGMU, with significant contribution and specialization in addiction psychiatry, to invite a respected speaker, Professor Adarsh Tripathi, sir.
Good morning, all. Now, Dr. Adarsh Tripathi is very well known speaker, doesn't require any introduction. Briefly, that formerly he was Professor of Psychiatry at KGMU, and recently he moved to the private sector. He is a well-known speaker, researcher, an academician. And I request Dr. Tripathi to make his presentation.
इसको शेयर करना होगा ऐसा एक मिनट आइए ना ऑनलाइन वाले ऑनलाइन कुछ ऐसे शेयर करना खड़े होते ही करना पड़ेगा
Anything I can do? You have to share your slides.
Is it visible?
I think it's coming up. Yep.
Hello. I hope the slides are visible now and I'm clearly audible. Can somebody confirm, please?
Yes.
Yes,
Thank you very much. So, I am going to make this conceptual presentation of how treatments in psychiatry evolved over the last 2-3 centuries and how we reached where we are at this moment in psychiatry. So what I'm going to do over the next in 20 minutes or so, that I will sort of map the landscape of psychiatric treatments that are there at our disposal right now, and how we utilize the treatments in different kind of clinical conditions, and how we make decisions in that regard, as well as what kind of conceptual shifts it brought to our understanding of psychiatric disorders in general. Because we can understand that treatments in psychiatry were influencing both the things, that some of the treatments were also influencing the way we understand psychiatric disorders and the way we conceptualize psychiatric disorders, because serendipitous discovery of many of the molecule and treatment methods has paved the way we think and we understand about many of the disorders. I will also talk about important historical milestones in psychiatry, what conceptual shift it brought, and also scientific breakthroughs and treatment evolution interplay, the way it moved. We are all aware that the history of psychiatry in pre-modern period is excuse me, we are waiting, slides are not moving.
You can.
My apologies for this interruption. So we were discussing that there have been shifts the way we think about psychiatric disorders and the way we approach about helping the individual suffering from psychiatric disorders. The psychiatry in pre-modern era, before any effective models of treatment were available, is largely linked with the asylum-based care. Then this moved to different stages, the way psychiatric disorders have been conceptualized and the treatment modalities have evolved. So the bird's eye view of major conceptual shift in psychiatry can be summarized as that moving from asylum to analysis, psychoanalysis, to understanding about molecules. Then the newer neuromodulation based strategies think of psychiatric disorder more in terms of circuits, that modulating circuits and manipulating neuronal excitability in certain specific kind of circuits result into the desired clinical responses. So this is what a basic of conceptual shift in psychiatry. So in pre-modern era, the most important basic shift was from punishment to humane care. That before 18th century, the most important psychiatric treatments that were available were dependent upon closing up the patient and separating them from society and keeping them in asylum for the safety of the person as well as more importantly for the safety of society. However, with the further evolution of understanding of psychiatric disorders, there have been shift from punishment to human care, and we know that the names of Philip Piniel and William Tuke, who introduced moral treatment in psychiatric disorders. So rather than based only on punishment model or separating or secluding them or restraining the individuals, the emphasis was shifted to compassion, structured routine in asylum life, and environmental healing. So making them becoming closer to nature and setting their biorhythm in more proper ways so that this environmental influence can help in healing process. And the key insights from this era can be that the mental illnesses begin to be seen as condition requiring care, not just confinement. And this also reverberate with the similar kind of thinking in different alternative methods of treatment. Like if you read about treatment of psychiatric disorder in Ayurveda, you will find references that in addition to treatment by some herbs, you'll find that the suggested treatment options for dissociation or hysteria are confinement in a room, hanging upside down in a well, and gentle beating. So these are the recommended treatment options in Ayurveda for conditions like dissociative disorders. So I would not say that we can think and ridicule these kind of thinkings in that era, but if we think in terms of that non-availability of any scientific concept for understanding of psychiatric disorders, as well as non-availability of any effective treatment options, led to think that people might be cured in this kind of way and they must be producing some sort of results also. Like in today's also, when I interact with the students, I would say that if you think about the outcome success rate in dissociative disorders, I would say that success rate will not be very different when we treat dissociative disorders by our medical method vis-a-vis the success rate of faith healing. The people who visit temples, who visit Dargah also get cured to a certain extent and they get well to certain time periods. But in scientific concept, we know that there are different kind of conceptual things that are helping them to heal. And those are not the way as a scientist we should promote or understand, but just for conceptual understanding that these are the model where faith-based systems or cultural-based concept do help in management of several psychiatric disorders, which were prevalent to the pre-scientific era also. But after this, there have been developments in modern medicine, and these developments led to development in psychiatry also. And some of the important key figures in psychiatry at that moment, which is it okay? No, it's okay. So the important concepts that started influencing the psychiatry is that the theories developed by Emil Kraepelin, who observed the course of people suffering from severe mental disorder and tried to classify that the severe mental disorders can be divided into dementia precox versus manic depressive illness. This led to understanding that the psychiatric disorders can be observed in a systemic way, and there is a separation in different kind of psychiatric disorders that can be classified. And this classification was primarily based on the phenomenology as well as long-term course and outcome of those patients. So this led a major shift in the way we understand psychiatric disorders. In the same way, around the same times, you can say that separated by a few decades, Sigmund Freud was developing his theories of psychodynamic or psychoanalysis. The work started in Europe, and the world wars interrupted his scientific trajectory of life, and he moved to USA, where the psychodynamic model became one of the most prominent model the way psychiatric disorders were understood at that time. The Freud was influential not only in the scientific circuits of modern medicine and psychiatry, but he also influenced the way people started understanding the human psyche and the way the interplay of internal psychological factors of humanity. And it also significantly influenced literature, art, and other kind of medium the way human psychology is understood at that time. And a sort of dual track evolution, we can say that began that in one way, some understanding and thinking related to biological psychiatry was being developed on the models that were initiated by Kraepelin, where systemic observation and careful evaluation of the patient was going on based on, and other was the hypothesis-based model that were developed by Freud. I would encourage the young students to read a book by Jeffrey Lieberman. The name is Shrink. It is a small handbook of 200-300 pages, but it is a very interesting history of psychiatry in these eras. And it shows that how the power structure in USA changed when the psychodynamic model came at the forefront. And some of the most important influential people who were deciding about the way psychiatric research and institutional models would move were dominated by psychodynamic model. So although psychodynamic model helped psychiatry in consolidating position as a modern medical branch, but it also, as per Jeffrey Lieberman, tried to suppress the biological model. As the most important people become psychodynamic people, so they suppressed all the alternative ways and research and biological models, at least for a few decades. But the development in psychiatry continued, and you all know that at the same time, some of the, at least from that point of view, breakthrough treatments. Now we can criticize that these were very improper and poorly scientific understood concepts, but insulin coma therapy, when it was introduced, was considered a breakthrough treatment. And so is lobotomy. it can be, as per the current standard, can be the most cruel and most kind of punishing treatment for any patient. But when the lobotomy was discovered, it was hailed as one of the most important scientific revolution, and Moniz has been given Nobel Prize for his discovery. He was a neurosurgeon. Electroconvulsive chemotherapy came around earlier 1938 something, that the different kind of models for influencing the brain and causing seizures were being produced. So the camphor therapy, where camphor was helped to bring about the seizures, and some beneficial effects were noticed. In the same way, Serenity and Binney has discovered that if we give regulated and controlled electric current through the brain, it might bring certain changes and it help in resolving some of the psychiatric signs and symptoms. And now we know that after discovery of this model, ECT has gone through several modifications, upgradations, understanding of scientific basis, as well as protocol changes. And till now, ECT remains one of the most effective treatment for several clinical conditions, most notably for severe depression, catatonia, and where patient is not cooperative or not accepting food, and severely suicidal kind of situations. The conceptual leap here in this era was that psychiatric disorders could be directly modulated by brain physiology. So this was a key understanding that if you do something with brain physiology, and there was a production of general seizures, it led to improvement in several kind of psychiatric signs and symptoms. Although the biological basis for this were discovered later, and we'll see that these biological understanding were utilized for development in psychiatry and several other domains also. After when these developments were being taking place, there were developments in other influential domains of psychiatry, which now we understand are one of the most basic key for our management of psychiatric disorders, that is psychopharmacology. The first molecules that were discovered in psychiatry were chlorpromazine, imipramine, and lithium. And we now know that these were the basic of the psychopharmacology in medications till date. Chlorpromazine was discovered by Jean Delay, the gentleman shown in the picture here. These molecules were discovered surreptitiously. These were not identified as molecules for psychiatric disorders. These were molecules that were identified for some other clinical conditions. And by chance, it was noticed that these molecules can help in improvement of psychiatric signs and symptoms also. So this led to refinements of its doses, the way it might function, the way it might help in people with psychiatric disorders. And psychopharmacology became the greatest enabler of modern psychiatry. And we can definitely understand that it is only the way the growth of psychopharmacology that helped in consolidating position of psychiatry as a useful and scientific branch of modern medicine. So the key shift that led to understanding of search for psychopharmacology was that mental illnesses are also caused by neurochemical imbalances. And it also led to theories of monoamine hypothesis for depressive disorders, dopamine hypothesis for psychotic disorders. And this was not only discovery of an effective treatment modality for psychiatry, it also led to change in the way we hypothesize and understand psychiatric disorders, and the neurochemical basis for psychiatric disorders were researched extensively, and now we know that great progress has been made on that front. Subsequently, in psychiatry, psychiatry was also benefited by developments in physics, developments in the modalities, which led to understanding of several other body organs, including the brain organs, and the strategies of neuroimaging like functional MRI, PET scanning, growth and developments in genetics, and as well as understanding of neuroplasticity. These things led to the change of understanding that the symptoms of psychiatric disorders, they are influenced by neurochemical basis. There are influences by the brain that they have a basis on neuro anatomical basis of the brain. But when we think about the functions of human psychology or human thing, they are not only localized area of brain that are responsible for production of physiology as well as pathology. There are circuits which help in doing the normal human physiological and psychological processes, as well as they impact the way symptoms are produced and the way the symptoms can be helped in the patient who are affected by psychiatric disorders. So these advances in neurosciences led to the conceptual transformation of that psychiatric disorders can also be dysfunction of brain circuits. In addition to the chemicals, not only limited by specific brain areas in certain cases, there are brain circuits that influence the psychiatric disorders, and this understanding also led to better conceptualization, the way we understand current neuromodulation strategies. And then the discovery of neuromodulation strategies happened, and we are standing here today that we know that strategies like repetitive transcranial magnetic stimulation, transcranial direct current stimulation, and deep brain stimulation, these technologies not only helped us to modulate brain areas in a more precise and specific ways to treat the specific targeted symptom in the patient who are suffering from those disorders, but they also led to understanding that there can be precision brain modulation in comparison to ECT. That was a general strategy to produce a generalized seizure. There was no precision in that kind of treatment. You cannot modulate that which kind of circuit you want to stimulate and which kind of neuronal system excitability you want to modulate. But these newer modalities of treatment led to this change that there are certain precision the way you want to influence the brain. So from global seizure reset to targeted circuit modulation, this is what neuromodulation is all about. Now we understand that ECT produces a widespread neurotransmitter surge, that changes in neurotransmitters level like changes in monoamine, GABA and glutamate. It also leads to changes in neuroendocrine system as well as influence neuroplasticity through BDNF and other pathways. And it leads to network effect, that is global synchronization and reset of dysfunctional brain network, as well as normalization of default mode network, hyperconnectivity, changes in hippocampal volume and in connectivity. So these are the prominent strategies and prominent models through which ECT is said to work. The newer neuromodulation system like RTMS causes focal electromagnetic induction, tDCS causes sub-threshold modulation of cortical excitability. So instead of global reset, these strategies are able to help in region-specific modulation of dysfunctional circuits like in depression, modulation of left dorsolateral prefrontal cortex. So the scientific leap that has happened in this era is that we move from whole organ level, that is brain level intervention, to circuit level intervention, specific and precise way. and also from irreversible lesion lobotomy to reversible targeted stimulation and suppression, tDCS and RTMS, they causes that circuit modulation work. Like in deep brain stimulation, there is possibility that it can be used for certain refractory conditions in a useful manner, and these breakthroughs revive interest in brain stimulation after pharmacology's limit. What about this limit that as we started understanding the brain in better way, at every story which I narrated in my presentation led to understanding of the brain and its system in relatively better way. But it also allowed us to see that what are the limits of this kind of newer intervention. So from asylum-based care to the precision psychiatry, which we are practicing both in terms of psychopharmacology and neuromodulation right now, we understand that a new layer of understanding was added, as well as a new level of limit was set to our understanding. So this is what current neuroscience is all about. tDCS, I hope that the next presenter will give a very detailed understanding about this thing, but just briefly, it modulate long-term potentiation as well as depression-like mechanism, work like NMDA receptor modulation, membrane polarization shift, and the key advantages are that these are plasticity can be paired with cognitive and behavioral tasks, so it can be a state-dependent neuromodulation also. Cognitive it can combine with cognitive remediation, and as well as there are things that it might influence the psychotherapy based interventions in psychiatry. So this is my last slide now. As we become excited with every new treatment strategy and avenue available in psychiatry, so there are a lot of hypes and a lot of over exaggerated expectations from treatment modalities also. tDCS stands at a position where this modality of treatment do have some clinically useful indications in psychiatric disorder. But this is not a treatment strategy which can be helpful for a large variety of clinical patients in all kind of symptoms. This strategy is the evidence base and effect size for most of the studies are reported in the range of small to moderate effect size. So these are not very high effect size data. This is what we need to understand. And also when we are claiming that this treatment strategy is very useful, it can be utilized and used in home-based care, domiciliary care. It can be utilized in variety of setting. It is very cheap and effective treatment. So there are potential that this strategy can also be misused. And we are already reading about that the people are using tDCS before exams for boosting their brain power, their attention and concentration. People are using tDCS for their interviews before their IS examinations. So I hope that as a scientist, this is also our duty that we need to sensitize the people that this is a treatment strategy, and the treatment strategy should only be delivered with the due clinical diligence in supervision of a person who is expert in the discipline, and it should not be misused, and the right kind of information should be disseminated to the public also. Thank you very much for your patient hearing. Thank you.
Thank you, sir, for such a nice and illustrative presentation. If the audience has any queries related to the topics, feel free to ask the questions to us, sir. Also, the online audience can ask questions from the sir.
Audience can write the question in chat box if you wish. So I hope there are no questions.
Good morning, sir. सर tDCS सीजर की थ्रेशोल्ड के लिए भी कुछ उसमें रहेगा अगर क्रोनिक सीजर पेशेंट हो गए और जो बहुत सारी एंटी एपिलेप्टिक पे चल रहे होंगे तो सर उसमें हेल्पफुल रहेगा क्या
जी I hope that the questions will be answered in the next presentation. The tDCS is being used as one of the treatment modality for refractory seizures. So it do modulate the neural excitability in the way which we can utilize in a clinical practice. So the next presentation will answer this question in detail.
That's also working on certain symptoms. Like these neuromodulation, we are also working on certain symptoms. How is that two are different?
Sir, first that I would say that this is going to be a very speculative answer. There is no clear-cut response to this question in the way I understand as of now. But the psychopharmacology intervenes the brain in the way the chemical systems are working. And the neuromodulations do influence the brain biochemistry through neuronal plasticity, synaptic level alteration, and neuronal excitability in those pathways. So, in the way we are observing clinically, both these systems can be utilized in a synergistic way for utility of our patients. Ultimately, many molecules and the neuromodulation strategies bring about the similar kind of changes in a specific way, like we commonly do in our clinical practice, that we combined molecules with some different neurotransmitter level, and we often see that in some of the patients we are able to get results which are clinically useful. So I hope that we utilize these treatment modalities which work through different ways of action, and we get some synergistic effect. That is what my best understanding is. If anybody would like to add. Yes.
When we use pharmacotherapy, once it reaches the circulation, the whole brain and all the organs, they are getting the molecule through the circulation. So it is a more of a centralized effect. But when we use neuromodulation, it's more precise. Suppose we know, for example, when we use antipsychotic dopamine blockers that blocks the mesolimbic circuit, mesocortical circuit, inframedullary thalamic circuits, the microstriatal circuits, all those circuits which are regulated by dopamine, they are blocked. But when we are using neuromodulation, it's more of a targeted, not all the circuits. Out of these 5 circuits, we are interested about just one circuit which is responsible for a particular group of manifestations. We can do the more precise intervention with this without affecting the other relevant circuits. So this gives a additional advantage to neuromodulation over pharmacotherapy and even electroconvulsive therapy. Electroconvulsive therapy causes lot of changes in the brain which are diffuse, not focal. But electroconvulsive therapy, the similar kind of effect that we can get with TMS and tDCS, which gives a focal neuromodulation without affecting the other brain areas.
What Sujit had said, I want to comment in relation to epilepsies. Like we know the mechanism of epilepsy is between the imbalance of the inhibitory and excitatory activities, interplay of the circuits. So, what it was going on.
So, with the drugs, we try to inhibit excitatory activities or potentiate inhibitory neurotransmission so that seizure threshold is increased and seizures are under control. But say if a circuit will have a number of synapses, neurotransmitters, molecules working at different level, and circuit can be excitatory, inhibitory, and if we are able to locate an excitatory circuit which is responsible in a very localized area for the causation of seizure, we can target and we can actually target the circuit and we can control seizures by this way by neuromodulation. So as he said, it is more specific, more precise kind of therapy, but the problem is in identifying that group that's Hello, sir. I'm Dr. Adarsh, associate professor in psychiatry. So first of all, I would like to thank that you have given a very good presentation on the conceptual progress and neuromodulation. So my question is, in the last part, you said that people are using it for cognitive enhancement before they do all those things. I am saying that it should be used like that, but I am just asking that, are there studies of use of tDCS in healthy individuals?
Yes.
Because I think some people say that they improve the working memory and all those memories. So if we see from those aspects, for example, if we sometimes people use some drug like propranolol to overcome the performance anxiety during interview or building science. So how do we see this studies in healthy individual effect of the tDCS in the working memory and use of it in some clinical?
Yes. So thank you for the question. Although I know that some of the answers will be in the next presentation, but I will briefly comment upon what you are trying to touch upon. See, health professional in general and mental health professionals are already blamed about medicalization of human problems in much way. That we already blame that you are keep on lowering the threshold for blood pressure, you are keep on lowering threshold for blood sugar, you are keep on lowering for threshold of several medical and psychiatric disorders to diagnose people who might not be that ill or that might not be in need of medical intervention. So this concept of medicalization of normal human existential experience is one thing which we always think about also as a health professional. We should always think that we should not try to overdo the things. We understand that some anxiety before examinations or before interview or before meeting an individual is not a adverse thing. It is usually productive thing, and lot of creativity, lot of human struggle, and lot of striving for the growth is coming through those kind of human emotions. So if we tend to over medicalize things and we tend to give intervention for all kind of difficult but non-pathological human emotions, there will be a difficult time where we'll be able to draw the lines. So we need to understand that where the need for medical interventions ends, and it is all the time wish for humans that they should not experience any pain or difficulty, and they should get any remedy that can magically treat them from any kind of difficulties or problems which they might be experiencing. So as a health professional, we should think about these boundaries, and we should respect these boundaries, that the interventions must not be used in an indiscriminate manner which led to fall the treatment. and which led to degrade the understanding of that treatment for even scientific use. So we must draw that line, and as a health professional, that is our duty to educate the general public, media, and other stockholders in the domain that this is a treatment strategy. It should be used for clinical population in a specific intervention, in specific indication, with a proper supervision of health professional. And this should not be a strategy for home-based self-treatment of, suppose if you try to do this, not very close to time, a patient will start experiencing anxiety and depression. Instead of going to doctor, they will order a machine of 20,000 from Amazon. They will ask the protocol from ChatGPT. They will see a YouTube video that how to apply the electrode, and they will try to treat their own depression and anxiety sitting in their home. Would you welcome this step? So as a health professional, I would say that this will not be a very welcome change in the way we practice medicine. But medicine practice is a very calibrated science, and that should be done in supervision of experts. So we should not promote the uses which are not very scientific. That is what my take is. Thank you.
Is there any query in the chat box?
So there are some. Okay.
Sure. So now on, we'll repeat the questions before our presenter answers. So if there are no more queries or comments, so we'll conclude this session. Thank you, sir, for the presentation.
Thank you. Thank you very much.
And infectious disease, and is a member secretary in Institutional Ethics Committee, KGMU Lucknow, to invite the speaker, Dr. Mohita Joshi ma'am, a well-known psychiatrist and assistant professor at Department of Psychiatry, KGMU Lucknow, with special areas of focus on neuromodulation and addiction psychiatry. I request the chairperson to invite the respected speaker, Dr. Mohita Joshi ma'am.
Dr. Mohita Joshi, who is in psychiatry and the PhD in brain modulation, as well as addiction psychiatry from NIMS. She is, as she has said, that she is assistant professor, and she has work-related 25 publications along with 7 book chapters. She will be giving us an overview of the tDCS and enlighten us with her thought. I invite Dr. Mohita Joshi.
Thank you so much, sir. Good morning, everyone.
You could present your slides in the presentation mode, then they're a bit larger. If you go to slide presentation.
Thank you, organizers, for this opportunity. I just want to confirm from the online participants whether my slides are visible and am I audible?
Yes, madam. Yes.
Thank you so much, sir. So my talk will be on understanding the transcranial direct current stimulation. So when we talk about the brain stimulation techniques, we often think that it is the product of a modern neuroscience. But actually, the fact is quite contrary to this fact. The use of electricity has predated the modern medicines by centuries. So let's understand this. So the first image depicts the torpedo fish or electric ray. So there is a story, interesting it is. There was a man who had a gout in his great toe and he was very much distressed with the pain. I'm talking about the centuries back, right? So he was so much distressed that I think probably he was depressed and had a lot of pain. So he went to near to the seashore and he was standing there. So suddenly he felt a shock like sensation. What happened? The torpedo fish bit him in the great toe. What did he felt? After 30 minutes, he felt that so much of pain which he was suffering from the ears suddenly vanished. So this finding was actually observed by scientist Scribonius Largus at that time, and subsequently they started using live fish for the treatment of headaches, pains, etc. So fast forward to the 18th century, the Alessandro Volta, he actually made a portable battery kind of thing which provided the regulated electricity. Fortunately, because of him, we don't have to shock our brains with the live fish now. After that, scientist Giovanni Aldini, he was the actually first person who used the electricity for the treatment of the psychiatric illnesses. So in this picture, you can see that he is stimulating himself with that voltaic pile. He was actually a researcher and scientist in the prison at that point of time in the 18th century I'm talking about. Although his experiments were very controversial and seemed crude, but he was the pioneer in treating the depression or the patients of melancholia. At that time, it was depression used to call melancholia. So he actually treated those patients. Now, fast forward to the 2000th century. Now we have the everything, the big voltaic pile, and the thing which we have to shock our brains with the life is now we have the portable, sleek, compact machine called tDCS, which actually is based upon the previous principles only. The only difference is that it is quite portable, it is very easy to use, but it works in the same principle. So here we have reached after like with the centuries, right? So before addressing about the TDS, I just want to show the tDCS machine because maybe some people have not seen it and might think it would have been unseen elephant. So just want to show this picture. It's just a machine with a small portable battery and it has two electrodes. It gives current through this simple battery and we tie it around the head like this as shown in the picture. So now coming to the main talk, what is tDCS? That is transcranial direct current stimulation. So it is a non-invasive technique. It means it stimulates the brain or inhibits the brain, basically changes the neuronal excitability, whatever, without breaching the skin or without needing the need of surgery, right? So it is one of the non-invasive techniques. Secondly, it is based upon the application of electric current, that is a direct current which is uninterrupted, flows from cathode to anode in one direction. What does it mean? It means the polarity in the electrode remains fixed. The current will always flow from one direction to the another. So one electrode will always be anode, other electrode would always be the cathode. Secondly, the important catch in this thing is it gives or it works through a very tiny amount of current, that is around 1 to 3 milliamps. While in ECT, almost average, we gave around 800 milliamps current. And so this is the basic difference. The amount of electric current which both these modality provides is quite different. Secondly, ECT produces the action potential in the neurons that thereby it leads to the production of seizures, convulsion. But here, the tDCS, the current which it produces, it actually just shifts the resting membrane potential of the neuron either towards the depolarization or either towards the hyperpolarization. But it itself will not cause the action potential. So now you will ask, what is the benefit of that? The benefit of that is because when action potential is produced, the neurons will fire and will produce convulsions, right? But if we are just shifting the resting membrane potential, so the seizures will not happen. So what ECTA is little stigmatized for its the production of convulsion actually. So it basically bypasses that thing. It is stimulating but not producing convulsion, and simultaneously it is causing some change in the neuronal excitability. And the best part is that the patient remains fully conscious. It is a OPD basis procedure. While in ECT, we have to anesthetize and we need a good setup and requirement of anesthesia is there, right? So now let's dive into the engine or how tDCS works into the brain. So what happens? Now I'll be talking about how current goes inside the brain. So when we switch on the stimulator, tDCS stimulator, the current will pass through the wire, then to the electrode, then the current will pass through the scalp or the skull, which provides a high resistance or impedance. Much of the current get lost in this process, but some amount of the current will breach this resistance and will ultimately reach to the CSF, which is actually a very high bioconductive material. Then after reaching to the CSF, this current or the electric field which has been produced there will now go to the gray matter of the brain, which we want, right? Now, look at the second picture. When the electric field would reach to the gray matter, in the form, there are gyri, right? There are folds. So neurons will be aligned in a different variation. The thing is that here is a catch, how electric field is going to actually stimulate the neurons, or which kind of neurons it is stimulating. So the neurons which are aligned parallel to the electric field will only get stimulated or inhibited through this electric field. The neurons which are lying perpendicular to this electric field will not have any effect of that electric field. So what is the inference of this? The inference is that everyone's brain has little different folding pattern, and when we are placing electrode over here, so we do not know how many number of neurons are actually being stimulated. It depends upon the anatomical variations of the person as well, so thereby it influences the variability in the treatment results of the people. Next, so this picture again shows that through the anode, the current goes inside the brain. It will, depolarize the neuron, and then this current will be collected with the help of cathode, and through this process, it will inhibit the other part of the brain which is underlying the cathode. This is the gyri head model. In this, it shows that, see, what we do in tDCS, we place two electrodes. So we think that, okay, the area which is beneath the anode will get depolarized, and the area which is beneath the cathode will get hyperpolarized or inhibited. But only this much doesn't happen. The current will actually flow from anode to cathode. In this pathway, the whole brain region which is between these electrodes the current will actually wash away through the whole brain tissue. So the thing which we were discussing previously, that is very specific. No, it is not. What happens through the computational modeling, we understand that, okay, the amount of current or the amount of stimulation or inhibition which happens to the brain region underlying just beneath the cathode or anode is the is the part of the brain that gets maximally stimulated, but the region between that electrodes also gets a certain amount of current. So exactly we do not know, like for example in depression, if I'm putting anode over left DLPFC, so it is the result of just stimulating left DLPFC what we are getting as an outcome, or is it some other networks are also being influenced with that current? So this is again the limitation of the mechanism of action. It is not fully explained, like exactly what. Okay, just give me a minute. There is a technical glitch. Okay, so here we are. Yeah. So I wanted to convey that the current doesn't travel in a straight line. Instead, it washes broadly across the entire head, diffusely affecting everything under and between the large sponges. Now, somebody might think, then how it is specific? It is specific in the way that the current the area beneath the electrode is the one which is maximally stimulated, but so thereby we say that it is little specific, but we are not very sure and specific, and this is the limitation of the conventional tDCS. Now, till now we talked about how current travels inside the brain. Now I would like to focus how exactly current leads to the outcome or the changes in the excitability. So here is a classical paper by Perpura et al. Which he wrote in 1965. So here you can see in these two graphs, when the anode was on, so the firing rate pattern has increased, right? The frequency has increased. While when the cathode was on, the firing rate disappeared, right? It decreased. So he said that whenever we, provide the electrical stimulus to the brain, and with the anode, it leads to the depolarization, and with the cathode, it leads to the hyperpolarization. Basically, if we go deep into that, the electric field changes the permeability of the ions. The current through the anode will cause the increase in the permeability of the sodium ions, thereby leading to the depolarization. In the same way, when we place cathode, then it will, make the inside of the cell more negative. Then thereby it leads to the hyperpolarization. Similarly, in the second paper by Fritz et al. In 2010, he showed that in the experiment in the mice hippocampus, he showed that after the application of the tDCS here, the normalized peak amplitude became elevated, and even it stayed there for some good amount of time. That is, for 150 minutes, the normalized peak amplitude remained elevated. Through this, we infer that tDCS does something within the synapse, right? It increases or strengthens the connections there. It alters something in the synapse, which leads to the plasticity. Thereby, it increased the normalized peak amplitude. Second thing which they observed in this research, that it was dependent upon the BDNF secretion. When they blocked the BDNF secretion by giving some medicines to the mice, then they saw this effect disappeared. Thirdly, they also noted that the mice with a well genotype had significant greater synaptic potentiation than the one with a met genotype. So by this paper, we infer that tDCS basically does long-term potentiation in the brain. Basically, it alters the synaptic plasticity. Secondly, the effect of the tDCS might depend upon the genetic makeup of that patient. Diving deeper into that molecular mechanism underlying the tDCS plastic effects. So whenever the anode will depolarize the neuron, the calcium will enter into the neuron in a bigger amount. it will ultimately release the magnesium blockade in the NMDA receptor, leading and more calcium will inflow into the neuron. AMPA receptors will get accumulated or will get active, and thereby it leads to the secretion of Crab protein, BDNF factors. So this was the actual demonstration or the research experiment he did in the animal model. So hereby it is again a proof that tDCS leads to the synaptic plasticity via the secretion of BDNF kind of factors. There are other mechanisms as well, which I will explain in brief. So in this experiment, the scientists noted that it doesn't only changes and it doesn't have the role only in the neuroplasticity. Even it alters the level of neurotransmitters inside the cell, which medication does. For example, when we apply anodal tDCS, it reduces the GABAergic secretion there. So thereby that area will get more excited, right? And thereby it will lead to the stimulation. Similarly, cathode will inhibit the glutamatergic transmission, and thereby it causes the inhibition of that area. So basically it plays with the GABA glutamate balance. Thereby it is having role in epilepsy. Somebody was asking in the last presentation. Another mechanism of action. See that some people argue that we give only a tiny amount of current, how can it will modulate a big bundle of neurons in the brain? So here is the answer for that. See, each neuron, okay, this is fine that the current which goes inside the brain will stimulate only certain amount of neuron, but the neuron is not a single entity. It is connected to multiple of neurons. It is connected to multiple networks. So when one neuron's activity gets changed, then the chemical changes or the transmission of that activity happens or gets amplified to the whole network of that network of the neuron population. So thereby the network effect or the amplification of the whole network activity, the tDCS shows its effect. As I mentioned previously, that just not the areas beneath the electrode, they not only get altered in their excitability, even the brain area between them also gets some amount of current, which have our glial cells, astrocytes, blood vessels. So now this is also under the research that there's a hypothesis that by computational modeling and the experiment, they have shown that even after the application of tDCS, the calcium activity inside the astrocyte cells also gets activated. And what does astrocytes do? For the actually long-lasting synaptic plasticity, the astrocytes needs to get activated, because they maintain the potassium balance, they maintain the calcium balance, and provide the and does the vasodilation of the arteriole there and provide the cerebral blood flow. So there might be the role of astrocytes as well in the effect of tDCS. Okay, so this was about the how tDCS works. Now coming into the main picture, where I can give, right? What are the indications? So it can be given in a variety of conditions, including psychiatric and neurological conditions. And even at the start, mainly neurologists were giving it mainly actually. After that, psychiatrists also started giving it for the variety of psychiatric disorder. So it has a good evidence base for the neurological disorders as well. For neurological disorders, even in our department, we have given tDCS for epilepsy, for the motor symptoms of Parkinsonism. Apart from that, it is used to enhance cognitive performance, learning, migraine, post-stroke rehabilitation condition, in which it is widely studied. And when we talk about the psychiatric disorders, so the common disorders like major depression, schizophrenia, OCD, substance use, in these conditions, tDCS has some evidence, which I'll be discussing later, and it is also being explored in the other conditions like ADHD, anxiety disorders, and for the research into the etiology, and even for the child psychiatric illnesses like ADHD, autism, tDCS has been explored, but the evidence base till now, it's not that great. So now, because now we are in the evidence, we talk about the evidence base of every treatment. We just don't give any kind of treatment without it's having good evidence. So let's talk about the evidence of tDCS in different psychiatric disorder. I'll be talking about this thing in a very brief way because the exact protocol and the parameters required to treat these illnesses would be discussed by Dr. Sujit Kumar sir in the next session. So it is important thing to note that tDCS has not achieved level A efficacy, that is a definite efficacy for the treatment of any of the disorder. One thing we should note, because when we give some treatment to the patient, we should also not glamorize everything that it is the ideal or the best thing. We should also tell the practical possibilities or the practical effectiveness of that treatment. However, it has probable efficacy, that is the level B evidence in the treatment of major depression, in the treatment of addiction and craving of alcohol use disorder, and for the fibromyalgia. The later international guidelines, which are evidence-based, published by Fregni et al. In 2021, in this study, the level of evidence of tDCS increased to level A, right? Similarly, for OCD and Tourette syndrome, tDCS still has level C evidence, while for the auditory hallucinations of the schizophrenia, it has level B evidence. Similarly, for addiction, it still has level B evidence for the craving or preventing relapses for alcohol. Now, because as I told you that the details of the protocol, exact protocol, what to give will be discussed later. So I'll be discussing the next parts. See, every patient in which I give tDCS will not respond, right? So there are many factors upon which the response and the benefit by which tDCS will have depends upon many factors, right? Some things, some points I already discussed, and some things which more we can discuss are here. So see, when we give tDCS, we have to set certain amount of current, whether I am giving 1 amps, 2 amps, how much milliampere current. So for 2 milliampere, it is said that the response of the current over the excitability of the neurons is linear. But beyond 2 or 3 amperes, we do not know. The research doesn't say that beyond 3 milliampere, anode will always depolarize, cathode will always hyperpolarize. So the amount of current you are giving is also a deciding factor. Secondly, the placement of electrodes, which brain region you are targeting. For example, if in OCD there are many brain regions which are targeted, for example, supplementary motor area, DLPFC, etc. So the effect will also be determined by the fact that where you are placing the electrode. Third thing is the size of electrode also matters, because the conventional tDCS has 5 into 7 centimeter square electrode, which is little broader, which is comparatively broader, I would say. So the effect or the current it would produce will not be just specific or precise, it will be little diffuse. So it will also determine the treatment effect. As I already mentioned, the gyri folding patterns, each one's head circumference is a little different, and the genetic makeup, these all determine the result. Fourthly, it is said that because tDCS just hyperpolarize or depolarize the neurons, it is actually not producing the action potential. So the neuron which is totally in resting state, the person is not doing anything. So in that state, just nudging the resting membrane potential may not produce the result. So if that neuron is little active, even by doing some task-based activities or doing something, so because the neuron is little active, and in that time, if we give tDCS, there are better chances that it will nudge the resting membrane potential in a better way. Right? So it also depends upon the brain state of the condition, whether the patient is actively engaging or not. right? And apart from that, pharmacological medications also interferes. It is said that GABAergic medications, anti-epileptic medications have basically they decreases the cortical excitability. So it will also be a determining factor in having the output of the patient. So because we do not that is why when we give tDCS to the patient, we try reducing the dose of benzodiazepines, etc. Right? So there's now, because till now we talked about the fact how it works, where we can give, what is the evidence base, but it is very important and ethical to know where it should not be given and where it would produce problems. So there are 4 absolute contraindications for that. If the person has some surgery and has some implant in the brain, has some compromised skin at the electrode site, there's a breach of the skin there, or having some facial metals and tattoos, because some tattoos also contains a metal containing dyes. That's why they are the absolute contraindication. First, let's understand why. Because see, in this picture, there's a plate in his head. So what happens? The current will always flow through the path of least resistance, and which the metal will provide this. So what happens? The whole current which is going from anode to cathode now will go through this plate, and the localized heating burns can happen, and it can distort the effect of the current which we want to give. That is, and we do not know, and we can't predict exactly what will happen with that electric current and plate, right? But it will definitely increase the chances of burning or problems there. And even if the brain is injured, for example, patient having some gliosis after certain thing, so even in that compromised brain, how the current will travel, we are not sure. So that is why these are the conditions in which we have to be a little cautious. They are contraindicated, but in the recent studies, with the help of computational modeling, it has been shown that if the plate inside the brain consists of ferromagnetic substances like titanium, it has little less propensity for deflecting the electric field or causing the problem. So in some case report, they have given tDCS in those patients as well who have implanted plates, etc. in the brain, but with the proper caution, right? With the proper caution is that they recommend that electrode should be placed far away from that area, as far as away from that area. Secondly, if the some imaging is available for that, we can locate exactly where is the problem, so that we are not touching that part. It should be done. However, this is the still in research. So for general settings, I would recommend these things should be taken as absolute contraindication. The safety regarding these is emerging, but it's still debatable. Okay. Now, regarding the safety of tDCS, the Bixen et al., who has worked immensely upon the tDCS, he has reported that any protocol with less than 40 minutes duration and less than 4 milliamps intensity hasn't produced any reports of serious adverse effect or irreversible injury till now. And his conclusion was based upon 33,200 sessions and upon 1,000 subjects. Right. Generally, tDCS carries a tag of being having the safest side effect margin. It is the actually safest technique and the most of the side effects which we get after tDCS are generally falls from the mild category. But yes, the main thing which we are worried, like production of seizures when we give RTMS, doesn't happen with it because it does not produce action potential. But again, we should be cautious in giving tDCS with thinking or applying every checklist before giving tDCS to the epilepsy patient. Secondly, it has a potential for the manic switch. In one case report, after the application of tDCS, the patient who had depression had the manic switch. So that history regarding the psychiatric illnesses should be asked. mostly the side effects which we get after the application of tDCS are headache, scalp pain, little burning sensation kind of thing. Some people report visual phosphenes kind of thing, because earlier we used to place one electrode over the supraorbital ridge. So here, because the optic nerve or retina gets stimulated, that is why phosphenes occurs. So these are some of the side effects. Before starting the tDCS procedure, you should adequately understand that is there a need to give tDCS for this particular patient? Is this patient's diagnosis suffice the indication of tDCS? Secondly, you should understand the contraindication. You should take some history regarding the contraindications of the tDCS. Thirdly, you should explain the procedure to the patient. Fourthly, you should tell the patient in advance the probable side effects, which falls into the milder category, but it is a good practice to always apply the side effect checklist after each session. And if the patient encounters some of these, then there are techniques by which we can overcome those side effects. If patient just reports the headache kind of thing, we can just give analgesics for a few sessions. In generally, it goes after 2-3 sessions, the patient gets adapted to this thing. Or if the patient reports any burning sensation, intense pain, then we have to check for the impedance. We can check for the site. We can check whether adequate saline is there or not in the response. So there are many things which by which we can allay the side effects of tDCS if at all it happens. But in general, I want to inculcate this thing in your mind that generally it has lesser side effects, but it doesn't mean that it is free of side effects. So when we encounter patients in a clinical population, we do get child population and pregnant females as well. So for those, for the current evidence says that this tDCS, actually the studies of the application of tDCS in pregnancies are sparse, but with the available literature that was published in 2018, which consisted of 13 studies dealing with the tDCS for depression in pregnancy, they reported that it can be given safely. There were no side effects in those pregnant females. And this is again the systematic literature review and of the 3 case reports only, in which 33 women were recruited and they reported no serious side effects, and even the results of tDCS application were encouraging. See how this is important for us to know, because in pregnancy we know that of 2-3% risk is always there with any of the medication. They have the potential to cause teratogenicity, but we want something which has less chance to cause teratogenicity. We are interested in that. And even the female is interested in that. So because the effect of tDCS is localized in her head, so practically the distance between the fetus and the scalp is a lot. For having an electric field to having some chance of stimulation in the uterus, they are quite minimal. So practically there are no chance of teratogenicity, but yes, because evidence is required, and till now only only minimal evidence is there which says that it is safe. So definitely we can try with proper informed consent. For the child and adolescent group, Bixen et al. Reported that after 2800 session in the child, which he applied for 500 child population, he reported no serious adverse event. But he also told the limitation of that. That his observation were based only upon a very less population. So it cannot be generalized. Overall, the safety evidence appears to be quite strong in this population as well. And even in our department, many of the theses has happened in the child adolescent group with the tDCS. So generally, we haven't encountered any side effect apart from mild pain, headache. So clinically, till now, our experience says it is safe, but the evidence is still emerging. Limitations with the conventional tDCS. As I mentioned that the current is actually washing the brain area between those 2 electrodes, right? And we do not because we do not want other network or other brain area to get stimulated or inhibit. We want to be more specific. So what this is the problem with the conventional TDS. So there is an answer for that. Now the technically advanced version of the tDCS, that is the high definition tDCS, has come into the picture. So what it does, it has a very small electrode which is around 12 size as compared to the electrodes which are as compared to the electrodes of the conventional tDCS, which were of 5 to 7 centimeters square. So because the size of the electrode is very small, and in this, okay, I'll show the picture as well. In which the electrode, which in this we only focus one area, either by anode or cathode, and the remaining 4 electrodes which are encircling the center electrode will actually will distribute the current. For example, I'll explain with this example. If I'm stimulating one area with the anode in the middle, so now the current has to be gathered by the cathode in the surrounding electrode, because now I have, now the 4 electrodes are there to take away that current and to complete the circuit. So the part or the amount of current each electrode has to, take back is very minimal. So for example, if I'm giving 2 milliamps current in the anode, the cathode surrounding it will only have to gather 0.1 or something 0.5 milliamps current, which is very insufficient for it to have an independent effect in the area beneath its its domain. So only that area will get stimulated. The other, because the amount of current the other electrode has to bear or take out is very less. Now it is not upon a single electrode, so that is why the chances of having other brain area to get stimulated or inhibited becomes very minimal with the HD tDCS. So thereby it increases the specificity and the focality and intensity of the current as well to the brain area. But because it is a more advanced technology, so the evidence for this is lesser available, I would say, as compared to the conventional tDCS. The evidence for this is still emerging. In the conditions, in the conditions when the patient is having compromised brain or having some actually pathology in the brain, for example, epilepsy, some gliosis, etc., then in those cases, HD tDCS would be the better answer, because it would be very precise. It would be very focal. It will not have effect on the other areas which we do not want to target. So this was only about the HD-tDCS because our workshop is basically concerned with the tDCS. So I'll be briefly discussing about the other 4 tDCS LEs. In a single machine of that tDCS, we have 4 options. By one mode we can give tDCS. By altering some parameters we can give TACS, that is transcranial alternating current stimulation, and third, transcranial pulse current stimulation, or transcranial random noise stimulation. All these 4 things have one thing in common, that they give weak they are dependent upon minute amount of current. They are weak intensity current producing thing, but the mechanism of action, how it influences the neuron, are a little different. Let's understand that in a brief way. So here is a figure. In the first figure, we are seeing the tDCS. So as I said, tDCS give direct current. The current, if I set the ramp up time, the current will reach to the maximum, then it will stay constant for the duration, for the entire duration for which I have applied the tDCS. And then after the duration gets over, it will come back to its stage. The anode will always depolarize, the cathode will always hyperpolarize. But in TACS, transcranial alternating current stimulation, what is happening? Okay, so what is happening? I'm talking about the 4th figure. The current is having sinusoidal wave. It is not constant. First thing. Second thing, the current will flow from anode to cathode and it will reverse its direction. So one thing is that it is different from tDCS. It is giving a sinusoidal kind of current. Secondly, the current is reversing its direction. First, it is going from anode to cathode, then cathode to anode, like that. So the two electrodes will not have polarity specific. They will always changing their polarity while giving the session. Coming to the third picture, TPCS, transcranial pulse current stimulation, in which what we do, we just as today, as we give brief pulse CCT or brief theta bus RTMS, in the similar way, it gives pulses of current with on and off period. So it is said that neurons are more sensitive to the changing electric field. This works in the concept behind developing this is this. Fourthly, we are seeing some chaotic kind of current sensation, right? So in this, what happened is TRNS, transcranial random noise stimulation. In this, the current will rapidly fluctuate with varying intensity, so which gives a noise kind of picture, which seems little chaotic, but it is good for the neurons. Let's understand this. See, our brain has a lot of billions of neurons. Each neuron is connected to another, to many neurons. So when we stimulate one neurons, by the chemical transmission, many neurons subsequently we get stimulated or inhibit. In this process, the entire network of those neurons would produce certain brain waves, which we study like alpha wave, beta wave, gamma wave. Every wave has different kind of function, right? So just imagine when we were school kids, when everyone and when I remember one thing from my school, when we were asked for the march past, everyone was moving in their own way for march past. But when the drum used to start beat, automatically our foots, how we used to step the foot, it gets aligned automatically with the drum beat. So this tax works in the similar way. We give this current, which would produce certain wave, which will actually align the brain wave activity, which is already existing in the neuron. This thing is called entrainment. Basically, the external rhythmic activity will entrain the internal neuronal activity. Thereby, it will have its effect. Third thing, with the TPCS, as I already mentioned, the changing electric field, the neurons are more sensitive to the changing electric field. Imagine this thing, if it is a dark room, and what I do, I just switch on the light, and after 2 minutes, then I will close. Then I will switch on again and again. If I'll do the same thing after 2 seconds, so your eyes will never get adapt. It will every time it will show contraction, dilation. In the similar way, if I give changing electric field in a predictable way, the neurons will have a more chance to remain active or to show better response in every stimulation, right? In the fourth picture, in the tRNS, what happens? Let me explain it with example. Imagine everyone has seen Lakshman Jhula, I guess, at least in pictures. Imagine we all are there in Lakshman Jhula. Some people might be just standing, some people might be walking in that, some people being. So if what happens if anyone shakes that Jhula, what will happen? Everybody will be forced to move, even the person who is standing. So compare it with the fact brain is that Lakshman Jhula, and the neurons, which are just resting, some are active, are like those people. And when we shake that, when we give a current in a random way, every neuron will have to get active. So thereby it causes the changes in excitability. I'm not going into the details of that. This is the final part of my presentation regarding the recent developments. So in the previous section also, people were very interested in knowing about the home-based device, ethical use, asking the questions regarding this. Let me tell you about it. So FDA in December 2025 has approved the device Flow Neuroscience FL100 for at-home treatment of major depressive disorder, which is based upon the Empower Phase 2 study. So this study is a large-scale randomized controlled trial which happened in the US in the patients of major depression, which included patients of both moderate to severe severity. In this, what happened? The patients were given battery kind of thing, which was actually a tDCS device, which was operated through the mobile app and got connected with the Bluetooth app. So the doctor saw the patient and saw that, okay, the patient is fulfilling the criteria of major depression. So he prescribed certain dose and that device to the patient for at-home service. At home, what patient does, the patient will switch on that device, will connect to the mobile app, and in the mobile app, the already inbuilt protocol would be there, which patient doesn't have control over it. The doctor would decide the protocol for that patient. And it strictly has only certain number of sessions. Like in this study, patients were given 5 sessions a week. The tDCS session, that is for one day, only one session was allowed. That was for 30 minutes. So once the patient will switch on that session, and after it gets completed, then the device will get locked for the next 24 hours. So patient can't reuse it just within the duration of 24 hours. So this was the setting. Secondly, the number of sessions for 1 week was also pre-decided. If the patient tries to, give more sessions to themselves at home by giving 6, 7, so patient will not be able to do that. So the setting control was with the doctor. The headset of that tDCS device already had the preset electrode, which was focusing upon their left DLPFC. Patient just has to sit in their home whenever he's free or she's free. They can switch on the device and can stimulate themselves for next 30 minutes. So the indication for which it is approved is major depression. The treatment protocol is it is given 5 days a week for first 2 weeks. Then it is given 2 to 3 times a week for next 3 weeks. Who controls the device? As I told, the doctor has the authority to decide upon the protocol, and it will be fixed. The patient will not be able to alter this. But the ethical concerns which people are interested and should know about it, that because something portable has been approved, so it opens a Pandora box of development of DIY tDCS in the market. Even in the Amazon, if you will see, you will get many companies tDCS. But the thing which we have to be mindful about is they are not controlled device. The amount of electricity it produces, it is not controlled. We do not know who is handling it. We do not know what will happen to the data which we are feeding upon it. So there are privacy concerns, there are ethical concerns. And if somebody is using this device at home without the doctors deciding upon the protocol, it would have problems. Why? Because if anything, because we know that in the brain also everything works upon the limit. If our neurons has this thing, when we overstimulate something, the brain slides its threshold to the higher level. So there would be certain counterproductive networks which might get activated. So you do not know that after overstimulating yourself with a self-made protocol, how it is going to influence your brain, right? Because brain is complex. A lot of networks are there which we do not know, and what gets stimulated we do not know. And even every brain is different, and if the patient of depression who has bipolarity would make the protocol himself at home, can have many experts. Even just not having the history of bipolarity, patient can have switches, patient can have a lot of problems. Everyone's brain anatomy is different, and so it can have any kind of implication if you use it by yourself. And even if with it is actually we can do anything to increase our working memory, but we do not know what implication it would have in the long term. That is the problem. So this is the main concern with it. The second recent development is the concept of priming. See, every patient doesn't respond with tDCS. So we always think, okay, what else we can do? How else we can make something better for the patient to show some response? So one thing is priming. The patient who do not show adequate response with the standard protocol, there is a recent thing called priming, which is based upon the principle of metaplasticity. So first, let's understand what is metaplasticity. To understand this, first let's understand the tipping point. This is very important. To prevent the brain from becoming overexcited, that is having seizures or completely comatose, brain itself has the ability to move the thresholds, right? If something is overstimulating our brain, the brain will increase the thresholds of the neurons. If something is constantly inhibiting, the threshold will automatically slide to the little lower side. So imagine one thing, if let's say for the hallucinations, we are trying to inhibit the temporoparietal area. So every time when I'm giving the inhibition protocol every day, the brain, because we are inhibiting, so the brain, the next neuronal activity depends upon the prior learned activity. So the threshold has already gone up, right, with the inhibition. So next time when I will give inhibition, it would become difficult for the next stimulation to show its effect. So what I can do is I can do priming. I can do little excitation for some time before actually doing the inhibition. So what will happen? The threshold will get little balanced. So the next stimulation will have long lasting after effects. So this is the priming. But the general considerations and things to keep in mind regarding this is interstimulation interval. The priming, the time, like if I give excitation for some time and suddenly starts inhibition, the priming will not happen. It has a very specific window. It will mostly the studies which have the studies which are there which have studied regarding priming says that the most important period of priming is between 3 minutes to 5 minutes. But we do not know what will happen if I prime the brain or if I keep the duration between the session more than that. What will happen below than that? So the timing of priming sessions is very important. The timing of intensity is very important because we do not know at what it is. In general, it is said that if I want to prime it for another stimulation, even the low intensity would work. But again, it is not as studied. It doesn't have much evidence, or we are even evolving in regarding this. And there is a lack of predictive biomarkers to assess the metaplasticity effect regarding the priming, and which can predict the patient's treatment response. So it is still in a development phase. There are many researches which are happening, which includes priming sessions as well. So this is a recent study which has published its protocol. In this study, for a patient who has hemiparetic upper limb, in this priming tDCS sessions have been planned, and even they have included task-based activity during that session. So basically they are doing actually two things. They have involved the task-based activity during the stimulation session, and before the stimulation they have included the priming session in order to facilitate the metaplasticity. So the results still are not published. So this was about the overview of tDCS. My conclusion is tDCS is a non-invasive modality of treatment. It gives a tiny amount of direct current that only shifts the resting membrane potential. And when we apply it for a good amount of duration and for the repeated sessions, it leads to the neuroplasticity. Anode, in general, it is a stimulatory. Cathode, in general, it is inhibitory. It has good safety margin, easy to use, portable devices, preferred if patient prefers non-medicinal treatment, which is often the case, and for the augmentation with the medicines, even with the therapy for the early and the enhanced effects. Thank you. Now I'm ready for the questions.
Thank you, Dr. Mohita, for an excellent elaborate introduction of tDCS, touching on most aspects involved in psychiatry as well as neurology. So we can have few questions. Anyone in the room who's interested, please identify himself and ask the question.
Good afternoon. I'm Dr. Tripathi, Assistant Professor at TS Mishra Medical College. Thank you, ma'am, for an insightful session. My query is that can we combine neuroimaging techniques with tDCS or other neuromodulation techniques to increase your precision and the consequent efficacy of treatment?
Okay. So among the audience, Madam.
I hope the online participants they have heard the question. There was a query last time. So if they have not understood or heard the question is whether you can combine the neuroimaging techniques in order to increase the precision of tDCS. Talking about.
Yes. Thank you for the question, ma'am. This part is actually been studied, and there are many studies which have happened, which have combined the neuroimaging and the application of tDCS. For the sake of the presentation, I have not included that part, but the computational modeling, FNIRS, which tells the functional status of the brain after the application of the tDCS, what are the functional changes happening, the EEG markers, and the MRI changes before and after. There are many studies which actually shows the changes, and they are being done. There are many case studies being published. I would not be able to point out for every study, but there are ample of studies which have done that. And even for the research purposes, which we do in medical colleges, even you can do that, Vicky, like for the predictive biomarkers, and what actually is there any change before and after the application of session, or what changes can happen after 4 weeks, after 8 weeks, with the help of fMRI, etc., FNIRS. You can even, by these methods, actually you are substantiating your object or your subjective findings, because now I'm applying the rating scale, which is a subjective method, but by involving the imaging you are actually getting some objective change. So these studies are already being done and in the process as well. Yes.
Hello, Mohita. Myself, Dr. Shrikrishna Nair, consultant psychiatrist in mental hospital, Bareilly. My question is, Mohita, please explain प्राइमिंग इन सिंपल वर्ड्स ना, जैसे तुमने दूसरी चीजें बताई जो कि प्राइमिंग हर पेशेंट में करनी है या फिर जिनमें रिस्पॉन्स नहीं आ रहा उन्हीं में करनी है, तो इसको थोड़ा सा.
Okay, so among the audience, sir has asked me the question about the priming, whether when to do it and in what patient I should think about it, right? Okay, so priming tDCS will not be the first choice, right? Because what are the evidence base? Priming doesn't have that much evidence. First of all, the international guidelines currently do not recommend it. So firstly, you will try to apply those protocols only which has good evidence. Secondly, yes, priming we can apply. They are under the research, and the research which has involved priming shows the better effect even in the patient who has not responded to the conventional protocols. So the cases in which the patient, you have applied good number of sessions, you have checked upon everything that no medication is interfering, the protocol was right, everything was good, but still the patient is not responding. For those patients, for now I'm saying, the priming can be tried before just becoming hopeless about the tDCS response. You can go for priming. Even the one thesis has been published from KGMU itself, in which I think for the patients of depression, for the elderly patients even, the priming session with the RTMS has been done before exciting the left GLPFC, and it shows better results as compared to the sessions which didn't include priming, right? So when the research which we have, the results which we have till now says that priming effect could be better than the simple conventional method. But I would suggest not to do it for a regular sessions. Go with the conventional and the protocol which have maximum evidence. But yes, for the research purpose and for the purpose, when you are not getting response in a conventional way, then go for priming. Okay, now we have a question in the chat. Do we plan our protocols after considering the concept of the tipping point, or we just ignore it completely? Also, like in RTMS, we have to find a new resting membrane threshold. Okay, so second question I would answer first. In RTMS, we find the resting membrane potential that is unique for each patient, but in tDCS, we do not have to do so. Second question is, do we plan our protocols after considering the concept of the tipping point, or we just ignore it completely? Okay. So as I told you that priming is a recent concept, right? It's a recent understanding. So we do not conventionally, we haven't thought about the tipping potential, right? Tipping point or the sliding potential. But after, the advancement in the research happening, like when the patients were not responding, probably the reasons behind that or the molecular mechanism was studied, and it came into the picture that, okay, this is also one thing, the sliding potential thing of the neurons. So anything which overexcites, or even if we are doing something like repeatedly, then maybe it is one of the reasons that why we are not getting effect in this. So okay, let's have some change in that and let's inculcate this theory as well. So conventionally we haven't thought about it. We used to just stimulate, or we just used to inhibit. But with the recent advancement in the understanding of the brain, and further elucidating the reasons why not everyone is responding, this theory came into the picture, and then we started thinking about this, and the priming came into the picture. Yeah.
Congratulations for this wonderful presentation. I just wanted to know that since HDTDCS, it targets a very narrow area, a focus area. So whether it will be useful to apply SDTDCS when we have neuronavigation like facilities, or if we are not very sure that what is the locality of the exact locus, then we can go for conventional tDCS, which would be better if we do not have this neuronavigation or such facilities.
Thank you, sir, for the question. So my answer would be little mixed, because see, neuronavigation techniques would not be available everywhere. It would not be feasible to do neuronavigation or computational modeling for every patient for now. For now, anything can happen in future. But so for that, because even in KGMC till now, we do not have neuronavigation. So for now, HTTDCS is the answer. But if we have, if in future neuronavigation becomes the common thing in clinical practice, and we are able to exactly identify where is the problem or where is the metabolic activity has altered. So in that case also, HDTDCS would be the answer. Why? Because now we know what is the problem. Now we know what is to be targeted. So HDTDCS is always a better option, even when the neuronavigation techniques are available. Because now we know where is the fault. So now we want to, we would like to specifically modulate that area only. We would not like to have a diffuse effect. Okay, if the pathology is diffuse, or we want, one thing I can add upon it, because in HDTDCS there's a limitation. We can either inhibit, or we can either stimulate the area. We can either stimulate or inhibit the area. We can only focus one brain area at one time. But if we want to simultaneously focus two area. For example, if I see, for example, in depression, we see hypoactivity in left DLPFC while hyperactivity in right DLPFC. Now I want to target both the things, right? And I see problems in the I see problems in both the areas through the neuronavigation. Then I would go for applying conventional tDCS. So my option for choosing tDCS or HDTDCS would depend upon the pathology, would depend how many brain areas I want to target upon. Thank you.
Good morning. Myself, Dr. Abhinav, Assistant Professor in the South Institute of Medical Science. Just want to hear your comment on safety profile in elderly, because there are some morphological changes, especially scalp skin becomes fragile, there is atrophy, there is CSF flow, there are neurodegenerative changes. So how is this the effect of tDCS in the
Can you be little? I did not understand the question. Can you?
I want to comment on safety profile in elderly population, as you typically explained it in the pregnant population and child mental health.
So tDCS is safe in elderly as well. I haven't mentioned that slide. It's safety in the elderly population, but it is safe. Yes, but because the brain in the elderly population with advancing age, the brain itself will have little atrophy. So the current again will have to reach or has to cover more distance, and in that process more the chances of electric field getting more dissipated will become more, right? So, but it is safe. It can have a determining value in the efficacy because of the increasing distance between skull and actual gray matter, but it is safe.
Questions. We'll finish after the last session. Please.
Thank you, ma'am. The presentation was very well explained. My question is first that you mentioned that facial metals we have to avoid in this patient. So, what kind of common facial metals do we include bases in that also? That is one question.
Anything apart from titanium material.
It's all over the face. We have to screen out the patient with real bases or who are wearing some.
Yes. If the patient has some dental filling, right? Silver. You have to ask about it. If it is having some filling which is not ferromagnetic, then it is fine, because then we, even in our setting, such people come. Then we ask your dentist who had done your filling, what was the material. Then if we know that material good, if we do not know, I check whether it is ferromagnetic or non-ferromagnetic, because that is the thing you should be mindful of. Yes.
So can I ask one last question? Okay. When you mentioned that if somebody is using the tDCS without supervision, so there may be a risk of switch or some other problems. So I just want no clinical experience all over these years, that whether you have encountered any such patient who was using by himself and came to the for help with some problem.
Till now, in our setting, there is no provision of home-based tDCS. So,
any patient who used by himself and then came to you for problem. Any such experience?
No, till now we haven't encountered any patient who has applied tDCS at home by himself. Or if you are just want to know what is the rate in how many people we have seen switches in RTMS, yes, we have seen people having switch with it, but in tDCS till now we haven't seen a patient with depression having a switch after tDCS.
You can have the last question, please.
Just comparing with RTMS, can we access deeper areas of brain with tDCS as well? When we have a deep coil,
if you are applying deep TMS, then it has, it can reach up to 5 to 7, some say, but at least up to 5 centimeter perfectly. The effect will not go that much deeper. It is limited to the superficial areas.
And we are like the process of, like you said, that it is not done always with neuronavigation, but if we have an option,
yes.
So which modality would be best to combine with tDCS if we want to perform research or something?
Okay, you are talking about therapy or you are talking about medicine?
Which imaging would be best if we want to conduct research and we want to be specific about the areas that we are targeting?
Okay.
So which imaging, like we now have options of FNIRS and other things. So which has the best evidence that if we want to have a targeted intervention, which kind of imaging should we use?
Then FNIRS, I would say it would give the status at the present time only. In the real time, it would show you the functional changes in the activity of the brain. I would say FNIRS.
And just one last question. You mentioned about priming, and you
Yes.
also mentioned that you use RTMS for priming,
Yes.
and then you used tDCS. What if, I just had a thought, we have a patient of schizophrenia with persistent auditory hallucinations, which we are giving ECT as such, which did not produce any effect. So would that ECT also serve as a priming?
Okay. Let
Maybe
me.
once.
Yes. It will not, because it will have diffused generalized effect on the brain, having even it is producing action potential. It is totally altering the membrane potential. So
I think we can mostly talk with the comments that it is still evolving. And with the neuromodulation protocols, it's better to divide them into two based on the site that you want to choose, the area that you want to stimulate, and the pathology where it is located. And then based on whether you want a functional protocol or you want to utilize the anatomy per se, that is important. Because now we have navigation protocols at several centers and we can utilize them. So, yeah. Thank you so much, Dr. Mohita Joshi, for an enlightening talk. We can close the talk and look forward to the next session.
thank you so much, sir.
Thank you so much, ma'am, for making such a complex topic into simple and engaging learning. We would request the chairperson to facilitate the speaker. Now I would request Professor Vivek Agarwal sir to kindly felicitate our chairperson.
Let's go here.
Thank you so much, sir.
Now I would welcome the respected chairperson, Professor Reena Yoon, sir, and Professor Adarsh Tripathi, sir, to invite the speaker, Professor Sujit Kumar Kar, to enlighten us on evidence of protocols of tDCS in neuropsychiatric disorders.
Yeah, hello. I'm calling. Thank you. Yeah, I'd like to invite Professor Sujit Kar to give his talk. Professor Kar is professor at the King George University. He's one of the most active publisher from India. He has been cited thousands of times, and he has been very active in suicide research, and his other big issue is neuromodulation. And he is chair or co-chair of the Global Psychiatric Association, and this is one of the reasons we collaborate. And he's also editor of Global Psychiatry Archives, and if you want to publish, you're very welcome. So I'm very excited to have his expertise and listen to his talk. And thanks, Sujit, for organizing this meeting and giving this talk now. Thank you.
Thank you, Professor Renner, for the kind introduction. Thank you, everyone. So by this time, we are familiar about what is tDCS, how it operates. Now, in my presentation, I will be talking about the practical aspects of using tDCS in various psychiatric conditions and neurological conditions. So I hope my slide is visible. Can anyone online participant confirm whether my slides are
It's
visible?
visible. It's visible,
Are they
but I would do it as slideshow, and then the picture is bigger.
I'm re-sharing it again. I hope it is visible now. And the slides are moving.
It's moving.
Is it moving?
Yes.
You are able to see the title slide now?
It's fine.
I'm moving to the third slide, fourth slide. Is it visible?
Yes, it's visible.
Okay. So, rightly pointed by Dr. Mohita that recently US FDA has approved tDCS home-based device for management of major depressive disorder. The important key point here is it is not only add-on treatment. FDA has also approved the use of home-based tDCS as a monotherapy. Those individuals who are not taking antidepressant treatment, they can be provided with home-based tDCS alone. So it is given for monotherapy as well as a augmenting treatment to the ongoing antidepressant treatment. And it is recommended for the adult population, those individuals with age more than 18 years. We can give it to 18 to 75 years. In that population, it was basically studied. So the FDA approval is having approval for a particular protocol, 30-minute protocol using the particular device, that is flow headset device, around 20 to 30 sessions as a add-on treatment to ongoing antidepressant treatment or as a monotherapy in patient diagnosed with major depressive disorder. So these are the specifications for approval. So one should not take this approval as a blanket approval for other devices, other electrode designs, and so. So usually when we are talking about neuromodulation, it is given approval for a particular coil or particular electrode of a particular device for a particular protocol. So it is very specific. So this approval we received in December 8th, 2025. It is based on a landmark study that is by Udham et al. It's a phase 2 randomized sham control trial involving more than 100 participants, a 10-week long intervention. So this trial was published in 2024 as a head of print, then subsequently published in 2025 October, and December FDA has approved the protocol. We all know that this has been already been discussed, that acute effect of tDCS is mediated through either depolarization or hyperpolarization. Underlying cortical area below the anode, they get depolarized. So they produce a excitatory effect. The underlying cortical area below the cathode, they get hyperpolarized. So they produce a inhibitory effect. This is the acute effect. Usually the acute effect lasts for few minutes, somewhere around 30 to 45 minutes. After 30 to 45 minutes, the acute effect goes. But there are some evidences that support that the acute effect may last as long as 24 hours. But that may not be that clinically relevant. So this will answer to some of the questions that are being raised during the first and second presentation. Whether suppose somebody is going for an interview or for an examination, whether before that tDCS can help theoretically. My slides are moving. I just want to confirm because some of the people they objected that it's not moving. And I'm sharing it again. Is it visible now? So acute effect in a therapeutic level lasts for around 30 to 45 minutes. Suppose somebody is receiving tDCS nearly 32 and the interview is scheduled after 30 minutes or 45 minutes, maybe it can be beneficial. How it can be beneficial? Like particularly DLPFC stimulation produces improvement in some of the basic cognitive parameters like attention, concentration, processing speed. So it may produce some therapeutic benefit theoretically. Practically, another thing is DLPFC stimulation is also having a mood elevating effect, reducing the anxiety. So may be beneficial for the anxiety and worry, apprehension, cognitive distortion, negative cognitions, those kind of things. But that effect is short lasting. Suppose your interview is after 2 hours, 3 hours, you may not get that benefit. So you cannot predict how long the interview will go and when your term will come. So maybe placebo effect you can get, but theoretically that long effect will not last. When you repeatedly administer tDCS, what happens? There is neuroplastic changes in the brain, synaptoplasticity, long-term potentiation, long-term depression, all those either strengthen a particular circuit or weaken a particular circuit. We target particular circuits during neuromodulation by using tDCS. Those circuits, pathological circuits, either they are hyperfunctional or hypofunctional, we need to regulate that. So that neuroplastic effect, when you repeatedly administer tDCS or TMS, both the things, tDCS and TMS, long run, they produces long-term potentiation and depression, producing a neuroplastic effect. And how long that effect will last? For both tDCS studies and TMS studies, it has been found that if you give for more than 10 sessions, at least 10 to 20 sessions, the after effect may last around 8 to 12 weeks. This is an average. There are individuals who report worsening of the symptoms immediately within few days of discontinuation of tDCS and TMS. And there are individuals who are maintained well even after months of discontinuation of the session of tDCS. So individual variations are there, but on an average, the after effect lasts for 8 to 12 weeks. So one need to be watchful here. This is what is the practical utility of this understanding. One need to be watchful for the initial 2 to 3 months of the follow-up. If you see that the patient's symptoms are again relapsing, again the symptoms are coming back, one may consider maintenance tDCS. If you see that the symptoms are maintained well on that same medication, probably you can continue on the same ongoing pharmacotherapy, remaining watchful for the subsequent follow-up visits. Once there is a deterioration of the symptoms, one may reconsider starting the maintenance tDCS. There is no clear-cut guideline that recommends how frequently one should give tDCS as a maintenance therapy. So one need to be it is a more of a decision of the clinician to whether to consider tDCS as a maintenance therapy, when to consider, at what frequency to consider. So I will be talking about that in the later part of my presentation. Say interesting image that say that the amount of electric current that we deliver in electroconvulsive therapy is 800 to 900 milliampere. The amount of electric current that we use in tDCS is somewhere ranging from 0.5 to 4 milliampere, but for a therapeutic purpose, mostly 0.5 to 3 milliampere. Commonly used is 2 milliampere. So 400 times less amount of electric current is being used. So suppose mostly people give electroconvulsive therapy almost at the threshold or supra threshold if you are going for a bitemporal or bifrontal ECT. If you are going for a right unilateral ECT, then you go for a 6 times the threshold, 5 to 6 times the threshold. But we are giving electric current for tDCS at a electric strength of 2 milliampere. It means that it is nearly 400 times less than the threshold. So there were some questions in the past and people usually ask, do we need to estimate the threshold of the neurons to give tDCS? Just like in ECT, we calculate the threshold. In TMS, we calculate the resting motor threshold. But do we need to measure something in tDCS as well before giving tDCS? Unfortunately, for threshold estimation, practically there is no technique is being used before giving tDCS. Neither we estimate the seizure threshold nor we estimate the resting motor threshold because we don't have anything to do with supra threshold or sub threshold. We need to fix to a particular, for all practical purposes, we are using a sub threshold, a very significantly lower sub threshold electrical stimulus for the modulation of the neurons. May it be 400 times less, may it be 420 times less, may it be 350 times less, but hardly matters, but it is a significantly sub threshold amount of electric current is being used. There are many factors that determine the after effect of tDCS. Rightly pointed out by Dr. Mohita that the duration of stimulation is important. People tried with a lot of experimentation. They tried giving electrical stimulation. My slides are visible. Anybody is asking anything? So duration of stimulation, people tried with experimenting with the duration. Beyond 40 minutes, there is no additional therapeutic benefit. Whatever things that you will get, that is more of a side effect. If you go less than 5 minutes, 10 minutes, then there is practically no benefit. So most of the protocols, they centered around somewhere around 15 minutes to 30 minutes. In some special situation, people went up to 40 minutes. Intensity of electric current again ranging from below 0.5 or at 0.5 milliampere electric strength. Practically, the neuromodulation that is happening, it's not going to translate into a clinical improvement. So 0.5 and below, it is clinically insignificant. When you go beyond 0.5 till 3 milliampere, there is a range of spectrum of change in the clinical symptoms. Beyond 4 milliampere, you are likely to get more side effect, no additional therapeutic benefit. So intensity of electric current that is conventionally being used is either 1.5, 2 or 3 milliampere electric current. Regarding the frequency of sessions, how frequently the sessions to be conducted? Initially, people started with 1 session per day, 5 working days in a week, over a period of 4 to 6 weeks, constituting around 20 to 30 sessions. Why 5 days a week? That 5 days are working days. So for a convenient reason, people choose 5 sessions in a week. But it's not a contraindication. If you are functioning all the 7 days in a week, you can give sessions consecutively in all the 7 days. Whether we can give more than 1 session in a given day, definitely we can give more session in a given day. Whether it is going to give additional benefit, ultimate therapeutic outcome will be same, but the response will be a bit faster. Whether it is going to produce more side effect, possible. It can produce more side effects. What type of side effects are likely to come if we keep more frequent sessions? More of a local side effects. There may be local irritation, burning sensation. If somebody is a fair skinned person, there will be erythema. So somebody asked whether it is safe for the elderly individuals. It is safe for the elderly individuals, but the thing that need to be considered is in elderly individual, the skins get thickened because of keratinization. During the aging process, there is again more calcification of the dura mater, thickening of the bone. So all those processes, these calcification, age-related changes, all these things, they offer more amount of resistance to passage of electric current. So probably in that scenario, you may consider 2 milliampere or 3 milliampere to overcome this resistance. So those calcification related changes are likely to happen in an aging individual. So suppose you are planning for more frequent sessions. What should be the inter-session interval? How frequently? What should be the gap? Initial research, people suggested that it is better to keep, if you are giving more than one session in a given day, inter-session interval should be kept around 3 to 5 hours. It is more of a safety reason and more of a safety reason. But it is found that if you keep the inter-session interval in an accelerated protocol around 30 minutes to 1 hour, the long-term plasticity, the long-term potentiation will be better. So keeping the sessions more nearer gives a better long-term plasticity. So it is if the patient is tolerating it well, you can keep the inter-session interval 30 minutes to 1 hour. 30 minutes to 1 hour gap. That also gives an additional advantage. Patient will not have to wait for a long time for the another session in that given day. Patient will come, they will have the first session, 30 minutes to 45 minutes interval gap, then second session they can go. A lot of mechanisms has been discussed about how tDCS works. There are some other hidden mechanisms. Why this people tried thinking of the hidden mechanisms? When people treated anxiety disorders using tDCS, they stimulated the left DLPFC and they got the therapeutic benefit by putting the anode. Some of the researchers, what they did the reverse thing. They put the anode over the right DLPFC and they got the benefit also. So stimulating the right DLPFC gives therapeutic benefit, stimulating the left DLPFC gives therapeutic benefit. People also tried it for treating craving for addiction related research. Some of the Indian studies and Western studies, they report that stimulating the left DLPFC reduces craving. And some of the other studies, they report that stimulating the right DLPFC, it reduces craving. So is it the cortical changes that is responsible for the therapeutic effect, or there's some hidden mechanisms that might be attributing to the therapeutic response? We all know that electric current, irrespective of its strength, they are known to stimulate the conductible tissues like muscles and neurons. So scalp is rich in the nerve endings of the trigeminal nerves. When you put two electrodes through which electric current is either going or coming out, and that is placed consecutively for a period of 20 minutes over the scalp, the underlying cortical neurons, which are the free nerve endings of the trigeminal nerves, they are also getting stimulated. The supranuclear connections, particularly locus coeruleus and other related areas, they are also getting stimulated. That's why many people, they report elevation of the mood following trigeminal nerve stimulation because of this release of norepinephrine and related mood elevating neurotransmitters from the locus coeruleus. So this is one mechanism that also explains. And this is how tDCS is also being used in the treatment of trigeminal neuralgia. People, those who are having persistent pain, symptoms despite of pharmacological treatment. Before nerve block, one may consider trigeminal nerve stimulation by using tDCS. People used to devices like transcutaneous electrical nerve stimulation like TENS. They are using it for management of pain, including trigeminal neuralgia. tDCS can be alternative device that can be used for the management of trigeminal neuralgia. There are evidences not only from animal studies, but from the human studies. Trigeminal nerve stimulation also important in improving the cognition, attention, concentration, arousal. Somebody who is not having ability to focus, not able to concentrate because of anxiety, worry, or some inherent tendency. So this is another answer to those people who are asking before examination, before interview, whether it is going to help. This is one possible explanation. Through trigeminal nerve stimulation, it may help. I'm not encouraging you to practice it, but it's a window to explore whether actually it is helpful or not. So hippocampal neuroplasticity can be mediated through trigeminal nerve stimulation through transcranial direct current stimulation. Now the thing is whether mostly we are using tDCS, or in the clinical research or clinical settings, people use tDCS for as an add-on treatment to the ongoing pharmacotherapy. Now the question is whether the ongoing pharmacotherapy can alter the therapeutic effect of tDCS. Of course, it can affect, because ultimately it is lending, we are dealing with either GABAergic inhibition or glutamatergic inhibition. So GABA and glutamatergic activity is modulated through the mood stabilizers that we are using for bipolar disorder. Valproate, carbamazepine, oxcarbazepine, lamotrigine, all these are affecting this GABA glutamate mediated pathways. So they raise the seizure threshold. So the cortical excitability reduces, so that may affect the therapeutic effect. Benzodiazepines, again, acting through GABA receptors, may reduce the therapeutic efficacy. So it is important to understand, suppose you are using these medications for the treatment of epilepsy. Valproate as a treatment of epilepsy you are giving. It is not important to stop or reduce the dose. Continue on the same dose and deliver the therapy tDCS. Suppose you want to, you are giving it as a mood stabilizer. Valproate as a mood stabilizer, not as an anti-epileptic agent. In this scenario, consider moving to a non-anti-epileptic mood stabilizer, which will have a limited effect on the GABA glutamatergic pathways. Now, tDCS, when it is delivered on the brain, in different brain regions, on different state of the brain, it is having different action. Suppose you are dealing with a healthy cortex. Healthy cortex, here I refers to the brain that is structurally normal and functionally in the molecular level, because we all know that all the psychiatric conditions, the functional level, there are some amount of alteration either in the neurotransmitter level or in the receptor level or in the intracellular signaling pathway level, somewhere it is there. So we cannot say that the brain is completely healthy in an individual which is not having any neurological illness but having a psychiatric illness. Exclusively depressive episode, there are some changes. So, but practical for this understanding, we consider that to be a structurally normal brain. In a structurally normal brain, when you deliver electric current, cathodal stimulation will produce stimulation, anodal modulation will produce an inhibitory effect. But suppose somebody is having a traumatic brain injury, there is an acute injury. Following acute traumatic brain injury, there is glutamatergic hyperactivity. So in that scenario, whether you put a cathode, it will produce stimulation. Whether you put a anode, that will produce stimulation. So ultimate effect is a stimulatory effect. As the condition progresses, in the subacute phase, the glutamatergic hyperactivity is replaced by GABAergic activity. Again, in that phase, if you plan for neuromodulation, you are not going to get the desired effect. So finally, maybe over several months, the brain plasticity and brain structural integrity, the normal healing pathway try to restore all those things. Nearly body tries to make the functionality nearly normal. In those scenarios, one may try with tDCS for neuromodulation if there is a persistent cognitive symptom, persistent mood symptom, persistent behavioral symptoms. So the point is, in the acute phase, response is unpredictable, so it is better to avoid. Subacute phase, again, response is unpredictable, better to avoid, unless otherwise you have an investigational modality that gives you a real-time feedback what is happening inside the brain. There are some practice guidelines in India as well as abroad, which gives a clinical framework how to use tDCS. You can refer to these guidelines. It has been given to you, and many of you as a resource material as well. Now we'll talk about the important protocols that are used for various psychiatric conditions as well as neurological conditions. Neurocognitive disorder is one of the commonest conditions where people use a lot of pharmacotherapy with limited improvement, but finally we focus on home-based care, how to do the rehabilitation, how to provide a supportive care. But neuromodulation like tDCS can be an opportunity where we can enhance the cognitive abilities, like dorsolateral prefrontal cortex can be stimulated by using the placement of anode, which produces some amount of cognitive benefits, particularly in the domains of attention, concentration, processing speed, the working memory, the verbal fluency, and some other components of executive function. Mostly people use 2 milliampere electric current around 15 to 30 minutes, one session per day, around 6 to 10 sessions. Here I'll say that the number of sessions, how many number of sessions to be given to see a noticeable benefit? Because of logistic issues, because of convenient issues, because of transport related issues, many people, they restricted the number of sessions. Mostly the trials, they restricted the number of sessions to 6 to 10 sessions. However, it is safely tolerated, as it has been reported by several case reports and studies, for a longer sessions. The more longer the session, that is more number of sessions you give for a longer period of time, the expected benefit is better. Depression is one of the commonest psychiatric indications where tDCS is being used. Why people target left DLPFC? It is not having a direct relation with the management of depression, but it is having an indirect association. There is an interesting association between left dorsolateral prefrontal cortex and anterocingulate cortex, particularly the subgenual part of the anterocingulate cortex. The part of anterocingulate cortex that is below the genu of corpus callosum, that is basically responsible for the processing of the emotions. And their cognitive processing is happening in the DLPFC related areas. So what happens in depression, in the dominant hemisphere, in the left hemisphere, there is a hyperactivity of the subgenual anterocingulate cortex that is responsible for the pathogenesis of depressive symptoms. And that hyperactivity, that area, we cannot target either with TMS or through tDCS, because that is deeply located somewhere in a hidden location medially. So we need to choose an area that is functionally connected to this area. So dorsolateral prefrontal cortex, which is easily amenable for neuromodulation, is functionally connected to subgenual anterocingulate cortex. And the functional connectivity is more of an anti-relation. Hyperactivity of subgenual anterocingulate cortex is leading to underactivity of left dorsolateral prefrontal cortex. So they have an inverse association. Suppose you stimulate the left dorsolateral prefrontal cortex, that becomes hyperactive or normoactive, and that will suppress the activity of subgenual anterocingulate cortex. This is how actually it works. So reverse happens with the opposite hemisphere. There is hyperactivity of right DLPFC and underactivity of right subgenual anterocingulate cortex. Suppose one good thing is you can target both the cortical areas through the conventional tDCS, putting the anode over the left DLPFC and cathode over the right DLPFC. Again, parameters 1 to 2 milliampere electric current, 20 to 30 minutes, one session per day, up to 20 sessions, but you can go beyond that. Even you can consider for the maintenance sessions. Coming to schizophrenia, schizophrenia is again three important constructs of symptoms that are being targeted in schizophrenia. One is auditory hallucination, which is a positive symptom. One is a negative symptoms, social withdrawal, apathy. And third domain is cognitive symptoms. In long run, there will be cognitive symptoms. Cognitive negative symptoms, they are related with left dorsolateral prefrontal cortex integrity, and the auditory hallucination, they are related to left temporoparietal junction hyperactivity. So there is a group of neurons in the temporoparietal junction. There is excessive corollary discharge of the neurons, which is responsible for auditory hallucination. So can we do these two activities simultaneously? Yes, it is possible with conventional tDCS. You can put the cathode over the left temporoparietal junction, and you can put the anode over the left DLPFC. Simultaneously, you can inhibit the temporoparietal junction and stimulate the dorsolateral prefrontal cortex, which is going to give you all the desired benefits. It is not essential that every patient will respond, but this is how the theoretical model, theoretical recommended medicine in schizophrenia, it is being done. Patients with schizophrenia, they don't respond too early in the course of treatment. It should not discourage you from discontinuing tDCS, considering it to be, it's not working in this patient. Many patients with schizophrenia, many patients with OCD, they respond late in the course of treatment. Maybe after 15 sessions, maybe after 20 sessions, they start responding. So if it is convenient for the patient, if it is well tolerated by the patient, you can continue before discarding tDCS. Substance use disorder is another condition which refers to variety of substances starting from tobacco, alcohol, cannabis, opioid, cocaine, and other newer psychoactive substances. Among the substances, tobacco and alcohol, these are the two conditions where tDCS is being extensively researched. Another study is with reference to opioid and cocaine, but the number of studies are quite less and mostly limited to very small sample size, less than 20 sample size. So the conflicting thing that I was talking earlier, started targeting right DLPFC, started targeting left DLPFC by putting a node using the same protocol, and they got benefit in some of the patients. So evidences are mostly in favor of anodal tDCS over left DLPFC, which produces some amount of cognitive enhancement or cognitive distortion correction in patients with substance use disorder. It reduces the anxiety level. It also reduces the craving, increases the abstinence duration. So it is doable. Obsessive compulsive disorder is another condition where tDCS is extensively studied. And the number of brain areas that are being evaluated in OCD is the maximum. In all the other conditions, people tried with DLPFC or some of the areas, temporoparietal junction, but OCD's area just started trying left dorsolateral prefrontal cortex, right DLPFC, cerebellum, supplementary motor area, pre-supplementary motor area. So variety of areas has been tried. So if you refer to the corticostriato-thalamocortical loop, we cannot target striatum and thalamus directly through these superficial neuromodulation techniques like TMS and tDCS, because finally these areas we cannot modulate. So for that we require either we have to go for deep TMS, or we need to have modification of the coil like double cone kind of coil, or we have to go for deep brain stimulation, particularly targeting the ventral aspect of antral limb of internal capsule, vallic. So actually that benefit is accidental finding. People tried targeting Parkinson disease for the vallic, and they also found some improvement in the OC related symptoms. They thought that striatum is involved with Parkinson disease, striatum is involved with OCD. There might be some common etiopathogenesis where we can use DBS and get the benefit. So this is how it started. That is invasive neuromodulation. Network meta-analysis suggests that that is among the neuromodulation, that is the best one. But we cannot recommend it for all the patients, or that facility is not everywhere available. Non-invasive neuromodulation can be alternative. I will try to finish in next 10 to 15 minutes. The current strength is 2 to 3 milliampere, 20 to 30 minutes protocols are given. Supplementary motor, in this context, just I want to highlight that supplementary motor area is functionally connected to striatum. Striatal hyperactivity is directly correlated with hyperactivity of the supplementary motor area. We cannot modulate the activity of striatum directly, but we can modulate the activity of supplementary motor area. So if you inhibit the supplementary motor area, striatal hyperactivity can be suppressed through indirect mechanism. So this is the reason why supplementary motor area was targeted in OCD. So hyperactivity of the supplementary motor area in OCD is a very complex thing. People tried using, they either inhibited the supplementary motor area. Many people, they also stimulated the supplementary motor area and they got the benefit. But consistent finding is hyperactivity of supplementary motor area. So the hypothesis behind hyperactivity of supplementary motor area in OCD, it can be a cause of OCD. Hyperactivity of the brain area leading to development of OCD symptoms and neurobiology of OCD. Hyperactivity of the striatum, second hypothesis is striatal hyperactivity can be a consequence of OCD. OCD happened, some brain changes happened, some abnormal aberrant functional connectivity happened, ultimately leading to hyperactivity of the striatum and supplementary motor area. So this is second hypothesis. Third is a compensatory mechanism. Because of OCD, some brain changes happen. Because of that, some deficit happened in the brain. And to overcome that deficit, supplementary motor area became hyperactive. So it's a compensatory mechanism. If it is a cause of OCD, it's very straightforward. It is causing OCD, inhibit it will improve the symptoms of OCD. But it is not always the same. We don't know in a given individual with OCD whether the hyperactivity is the cause or the consequence or the compensation through a cross-sectional study. For that, we need to have a longitudinal study or a study where you induce hyperactivity and look for the OC symptoms, which is not ethically acceptable. Maybe you can do it in the experimental animals. So this is the area where further studies are going on to explore. Can we predict neuromodulation on the basis of neuroimaging hyperactivity changes? So studies are going on. Autism is another condition where target symptoms were executive function, social cognition, and behavioral symptoms using 1 to 2 milliampere electric current. Because autism patients, when there is a hypersensitivity to stimulus, may be there. Some of them are hypersensitive, some are hyposensitive. If the individual is hypersensitive, even with a very low frequency intensity, they may be sensitive to that, they may be reactive to that. So one may try with a low intensity electric current like 1 milliampere. Attention deficit hyperactivity disorder. Again, DLPFC is targeted anodal stimulation targeting left DLPFC produces some improvement in the cognitive symptoms, particularly attention, concentration, and the executive functions. Tourette syndrome, again, for the tic, one can target the pre-supplementary motor area and left motor area with cathode, which will suppress the cortical activity and can suppress the tics. You can see there are places where the electrode is placed over the arm, deltoid, mastoid, supraorbital, these areas. These are actually neutral sites. Placing electrode there will not produce any neuromodulation over that area. Suppose you want to target a single cortical area for neuromodulation, you can put the desired electrode over that area. It may be a cathode, it may be a anode. The other electrode can be put over a neutral site. Suppose you are targeting for dual cortical modulation, like in depression, I will be interested in doing stimulation of the left DLPFC and inhibition of the right DLPFC. I can use both of my electrodes, putting one anode over the left DLPFC, cathode over the right DLPFC. But for anxiety disorder, I may be interested in reducing the hyperarousal symptoms of the left DLPFC by putting the cathode, or by cognitive errors by putting the in the left DLPFC by putting the left DLPFC anode there, and the neutral electrode I want to put it in a site, not in a cortical site. I can put over the deltoid, over the mastoid, over the arm. or over the right supraorbital ridge. Beyond psychiatry, it can be used in traumatic brain injury, particularly people used it in mostly in the chronic traumatic brain injury patients with a mild traumatic brain injury. A lot of variations in the target sites because you cannot predict which area of the brain is going to be affected. Traumatic brain injury can affect any of the areas. So where to put the electrode, that if it is a superficially accessible area, if the lesion was there in those areas, you can target those areas. Otherwise, if it's a deep-seated area, maybe tDCS may not be the appropriate choice if you are not getting a functionally connected area to that area. Challenges are mostly related to finding optimal protocol. So placement of tDCS, anodal tDCS causes improvement of the motor skills, language processing, memory consolidation, whereas cathodal placement is beneficial in suppressing the hyperarousal. Mostly 1 to 2 milliampere electric current, 20 minutes protocol, 10 to 20 sessions are given. tDCS can also be used in the management of Parkinson's disease. This is one of the systematic review meta-analysis that I'm referring to. They used 21 studies that use tDCS as a modality of treatment for Parkinson's disease, including more than 730 patients. So they found that tDCS causes improvement in the cognitive performance. Particularly patients with Parkinson's disease, they have either cognitive symptoms due to anticholinergic use, they have cognitive symptoms due to ongoing neurodegenerative process in the other brain areas, or dementia associated with Parkinson's disease. So cognitive functioning is grossly affected in majority of the patients with Parkinson's disease, at least in the advanced stages. In those scenarios, tDCS is beneficial. But regarding the motor symptoms, which is actually the core symptom of Parkinson's disease, which is actually bothering the patient and the family member the most, the evidences are insufficient. TMS-related evidences are more favoring Parkinson's disease, but tDCS-related research, mostly it is limited by small sample size. Mostly it is understudied. Another area, another systematic review meta-analysis that evaluated two important domains, motor domain and cognitive domain. Lot of heterogeneity is there in the study. They found no improvement, no difference in the motor function, gait, and cognition when they did the intergroup comparison of active and SAM. But they did some advanced statistical analysis, meta-regression analysis. They found small positive effect in Parkinson's disease in those individuals who are young individuals and having milder symptoms. In pain-related conditions associated with Parkinson's disease, people used tDCS, and significant improvement happened after tDCS targeting the primary motor cortex. So Dr. Mohita has already highlighted that fibromyalgia, pain-related conditions where tDCS is having a better efficacy level B. So it is in the same paradigm. tDCS is also being used in some of the other meta-analysis. They report that there is improvement in the gait and balance in individuals with Parkinson's disease. So you are getting, there are evidences, there is no improvement. SAM and tDCS, active tDCS, there are evidences of mild improvement. There are evidences of better improvement with active tDCS. So there are a spectrum of evidences. Now all these studies, they conclude that lot of heterogeneity is there and small sample size is there. What we require is a larger sample size to have a more conclusive evidence. tDCS, when combined with some physiotherapy measures like improving mobility, stability, other management exercises. So it is as an add-on management, combining tDCS with all these physiotherapy measures, it helps in improvement in the motor functions. Then these exercises alone. So probably when you are combining the physical exercises, so it is not a resting state of the brain. Motor activity is happening. So some amount of cortical areas are getting stimulated and you are modulating the activity of that brain areas through tDCS. So probably now the thing is, can tDCS combining in an activated brain gives a better result? That activation can be achieved through either priming or through some physical exercises or motor activities. In the management of epilepsy, tDCS has been used. The findings suggest that tDCS significantly reduces the seizure frequency, particularly those seizure epilepsy patients, those where we can easily identify the focus of epilepsy, epileptic focus. A few minutes back, Dr. Sharma was also saying that it is important to identify that circuit that is being involved in epilepsy. If you can correctly identify that circuit, then you can probably effectively modulate it and control seizure. Not every individuals where will get that identifiable set. Majority of the patients with epilepsy may have a normal EEG finding, may have a normal neuroimaging finding, but still epilepsy process is going on. In those scenarios, targeting the appropriate focus becomes difficult. But having epileptic focus, either pathological lesion or traumatic brain injury or tuberculoma, or those scenarios, it's quite easy. So cathodal tDCS is mostly useful in patients with refractory epilepsy because ultimately we need to inhibit the hyperactive epileptic focus by cathode. So putting cathode over the epileptic focus and putting the anode over a neutral site, that is the usual way of dealing with epilepsy. In our center, we tried using tDCS in a series of patients with refractory epilepsy. So in those scenarios, patients were around 6 to 8 anti-epileptic medications at the time of initiation of tDCS. 2 or 3 patients, they were also undergone epilepsy surgery. And despite of that, the epilepsy process was going on. When we started tDCS as an add-on treatment, the frequency of epilepsy episodes in the day and the severity of the episodes and the duration of seizure-free interval, all those things has increased. However, it is limited to, our experience is limited to some case, 6 to 7 cases. We need to have more number of similar scenarios to substantiate this evidence. In the management of pain, tDCS is also being used. In the pain management, there are two important areas. One is a cognitive component of pain. So somebody who is having chronic pain, they have some negative self-appraisal about the health, about the person, about the illness. They have a lot of cognitive errors. They have comorbid anxiety, depressive symptoms because of the long-standing disabling condition. So, and those conditions further aggravate the persistence of the pain. Second is area that is directly related to pain, that is sensory cortex, thalamus, and sensory motor integration. So we can target either DLPFC or the primary motor cortex. Evidences support that stimulating the primary motor cortex can cause sensory motor integration. Through sensory motor integration, it can cause neuromodulation. It can inhibit the pain perception, pain severity. Even DLPFC stimulation will also produce similar kind of effects. So in chronic low back pain, people tried using tDCS as a modality of treatment, and they found that there is significant improvement, a reduction in the pain symptoms in comparison to the SAM counterpart. Patients with fibromyalgia, they also reported improvement in the pain symptoms. So again, target is DLPFC and primary motor cortex. tDCS was used in patients with stroke, those who are having a lot of motor deficit following stroke. They used tDCS as a add-on treatment to constraint-induced movement therapy in post-stroke patient, and they found that it is safe, well tolerated, and there is some improvement in the motor symptoms. But mostly the duration of intervention that is required for stroke patient is longer. In our setup, we had given 2 patients with stroke with tDCS. 1 patient was referred from Dehradun, where the patient is having significant motor deficits because she had multiple episodes of stroke. So both right side and left side hemispheres, both sides are affected. So we started with the principle, the deficits are huge. The areas of brain affected are very significant areas are affected. Now, wherever you put the electrode, some amount of benefit is going to happen because the underlying cortex is dysfunctional. The second thing, the negative part is wherever you put the electrode, some amount of deficit will remain because large area of the brain is affected, bilateral it is affected. The patient was wheelchair bound. After 40 sessions of tDCS, patient was able to walk with support. So, and it was an add-on to the ongoing physiotherapy. So, it can be tried. So, stroke recovery, it facilitates that process. So, it is feasible and safe. Particularly in the treatment of aphasia, it can also be as a add-on treatment. In aphasia, what happens when the dominant hemisphere Broca's area is affected, the contralateral homologous area becomes hyperactivated because of the cortical reorganization to overtake the activity of the Broca's area. So that hyperactivity interferes in the recovery of the Broca's area. So one can stimulate the Broca's area by putting the anode there and inhibit the opposite side, right side Broca's homologous area by putting the cathode there. So you can get the benefit. So in different phases of aphasia, it has been tried. There is some improvement in social participation related things in terms of neuromodulation. So in the systematic review and network meta-analysis of randomized controlled trials that used tDCS for the management of aphasia, they found that they tried to rank what type of neuromodulation tDCS is more effective. If you are looking for functional communication, probably anodal stimulation is more beneficial. If you are looking for naming the nouns, cathodal stimulation is bit superior. In terms of performance of the naming of the verbs, then cathodal stimulation probably better than anodal. Marginal, they are different, 0.63 and 0.64. If you are looking for safety, of course, it is SAM. It is not having any effect, so it is not going to produce side effects as well. Anodal tDCS produces benefit in patients of migraine, particularly targeting the primary motor cortex. So it reduces the number of attacks. Pain intensity is also being reduced. Attack duration is being reduced. The need for analgesics has been also reduced. So tDCS can be a modality which can be used in the management of migraine, particularly refractory migraine. Fibromyalgia, migraine, neuropathic pain, spinal cord related injury related pain, stroke related conditions, they respond to tDCS. There are some practical components. We'll be talking about it during the hands-on training in the afternoon session. Safety wise, if you compare, tDCS is more safer than TMS and ECT. But if you talk about efficacy, particularly in the context of depression, ECT is most efficacious than TMS. tDCS is having relatively lesser efficacy than TMS and ECT. There was a network meta-analysis evaluating different neuromodulation techniques in the acute management of depressive episode. They found out that ECT is most efficacious, but tDCS is, though relatively less efficacious, but it becomes more acceptable. We did some of the randomized clinical trials several years back. Dr. Babli did it, tDCS as an early augmentation in the treatment of depression, which is published in Asian Journal of Psychiatry. Dr. Aditya did it for adolescent OCD patients as an early augmentation strategy. And Dr. Arundhati used tDCS as an anti-craving measure in patients with alcohol use disorder. Dr. Lokesh is present here today. He used it for the management of OCD in adult patients. Dr. Soumya, she is also senior resident in our department. She used it in the management of adolescent depression. All these studies where we use tDCS as an early augmentation strategy. And the finding is that there is a beneficial effect of tDCS as an add-on treatment comparison to the SAM counterpart. If you add it early in the course of treatment, the patient can resume the functioning early and can have a early reduction of the symptoms. So there are some techniques that we are going to discuss in the afternoon. Here I will stop. Thank you so much.
Thank you, Dr. Sujit. It was very comprehensive as well as exhaustive session. I hope that a lot of your questions or queries are already answered. The session is open for questions now, please.
Sir, thank you first of all for wonderfully explaining all the things in simple words. In the start of your presentation, you compared tDCS with ECT just for the sake of our understanding, which brought some curiosity to my mind. My first question is, do we need titration in the dosing schedule with tDCS as we need in ECT?
No, we don't have that titration process option in tDCS. Usually you start with a defined protocol, you continue with that same protocol over a period of time. If you want to do some modification in the protocol, like if you don't get any response at least after 10 to 20 sessions, you want to do some modification in the protocol, you can change the site, you can do priming. Either you can do priming by tDCS or you can do priming with TMS, but there is no possibility of titrating. Titration possibility comes when there is patient is reporting benefit, but there is side effect. There is pricking sensation, there is burning sensation, formation of scald. In those conditions, you can titrate the dose of electric current in terms of reducing the duration, in terms of reducing the intensity of electric current. So those titration you can do if there is a perceived benefit. At the same time, there is some side effect that is being reported.
Sir, in continuation of that question, when we use tDCS as an augmenting agent or with other psychotropic drugs, do we need any change in the dosing schedule? Or?
No, you can continue with the same dose of the psychotropic medication. Dosing modification is required for those medications that alter the cortical excitability. That I have already mentioned, that benzodiazepine or mood stabilizer with anti-epileptic properties that are being used, this can be reduced to a minimum possible dose. But there are many research where people used tDCS as an add-on treatment with concomitant mood stabilizers and concomitant benzodiazepines, but it is better to keep the dose as minimum possible.
So we can face any cognitive side effect when we use?
In those scenarios, because you are not increasing the dose of electric current, the dose is remaining same. So cognitive side effect will not be there, but the therapeutic efficacy will be compromised.
And sir, on the other line, in the start of the presentation, you said that theoretically it can help with anxiety issues, performance anxiety issues. So does it can have any rebound phenomena? It can be weak with time, but
yeah,
can it have rebound?
Because the effect of tDCS is short lasting. So once the effect will go, the phenomenon, the underlying things will come out again.
Regarding the dose modification, just wanted to add one more thing. Because in ECT, there is an intervening phenomena from stimulation to response, that is seizure, which you can observe and modulate that what is the minimum effective period of seizure that is required, and if the seizure is prolonged. So those are the intervening phenomena. In the neural brain stimulation, they are measuring the response by the clinical pointers, which are not often quickly and easily measurable. That is why there is no possibility of doing modification in terms of observing efficacy.
Sir, actually, I wanted to ask a question. Sir, if we are doing a study, say on anxiety disorder and comparing the efficacy of tDCS in anxiety disorder, and we have to give benzodiazepines, then in that case, SOS benzodiazepines would be preferred or a fixed minimum dose benzodiazepine and a short-acting benzodiazepine or a longer one would be to minimize the harm on tDCS.
Okay. SOS benzodiazepine will be more harmful. You say that suppose 3 days you have taken it, 2 days you have not taken it. So the cortical excitability will be more of a fluctuating kind of thing. Suppose somebody is taking a benzodiazepine at a constantly lower dose, that is more acceptable, that most studies allow. Suppose you use a long-acting benzodiazepine, then it will be having a round-the-clock effect. But if you are using a short-acting benzodiazepine, then you need to think of the session when you are giving that session. How many hours after the benzodiazepine use? It's very difficult to monitor that patient will take benzodiazepine in the morning and exactly at a particular time in the afternoon or in the evening, you will deliver the therapy. Patient may take the medication a bit early, may come a bit early, therapy may become late. So again, it is affecting the cortical excitability. So a uniform effect is not expected if somebody is taking short-acting benzodiazepine or patient is taking SOS benzodiazepine. This is for research purpose. For clinical purpose, it can be done. But for a research purpose, if you want to look for a particular electrophysiological finding or cortical activity through serial monitoring, so you should follow that protocol uniformly. If the patient is on benzodiazepine, they should be in a given range of dose throughout the study period. That flexibility is there, but you need to fix it a priori so that the findings can be evaluated in this line.
Thank you so much, sir, for your wonderful session. My question is a little more practical. If I think of introducing this technique to my department or in clinical practice, is there any regulatory protocol that we are supposed to follow in order to introduce this?
If you want to do it, procure it for your department, particularly in India, procuring a device in the institution requires some of the things you need to see. One is whether that device is a mandatory requirement for running a undergraduate or postgraduate curriculum. Till now, tDCS is not a mandatory requirement for undergraduate curriculum. tDCS can be as an optional requirement. TMS tDCS are optional requirement. It would be better if you can have those facilities in your institute. Suppose your department is having a postgraduate course, you can have it for the postgraduate students learning. Third thing is regarding whether the device is approved by Indian regulatory authorities or not. Indian regulatory authorities like CDSCO has approved tDCS in the management of psychiatric and neurological conditions. So that approval is there. Then from the institution point of view, the thing for which the device is being indicated, how many number of patients you are getting in your institution, whether you are able to utilize that facility. So you need to convince your administration that this is the patient footfall, this is the need, and this is the requirement. So accordingly, you can pursue for that.
Sir, myself, Dr. Joshi, Assistant Professor, TS Medical College. So I want to ask to Joshi. The first question is that whether you have seen any case where the patient was stable on a psychiatric medication, like we say, but due to adverse effect, he don't want to continue that much amount of drugs, or due to he want to use the drug and they shifted it to tDCS. And then you will be able to reduce the dose for that augmented later on. And the effect persisted. And patient may say, oh, the low works rate. Have you seen any cases like this?
Yeah. We have used tDCS as a add-on. You can please sit. We can use tDCS as a add-on treatment. There are patients who are stable on treatment, but over a period of time, they discontinued the medication or they reduced the dose of their own, and some of the symptoms they emerged. They reported that medications are costly, and fortunately, we are offering tDCS free of cost at our institute. So for the acute management of the symptoms, we enrolled few of these patients for add-on tDCS with a relatively lower dose of serotonergic medication, and they were maintained well. And a few of these patients, they are on maintenance tDCS. Few are maintenance tDCS, few are on maintenance TMS. Regarding the second question was related to.
The second question I'm going to ask. The second question is that, like you are saying, you are saying that in last year you have approved it for home use of tDCS. Do you see in future any private practice the psychiatrists can be able to provide tDCS device to the patient?
Of course.
Like, and
after this FDA approval, there are 2 Indian companies and a few more companies. They are coming with devices. They are remotely operated. To the best of my knowledge, 2 Indian companies, they introduced tDCS machines which are available in a affordable price. They can be remotely operated. They are basically meant for the patient can come and they take the machine on rent, and they can do the neuromodulation at home as decided by the clinician. And additionally, that device gives a benefit of simultaneous recording of the EEG during the session. So that type of devices are coming and in an affordable price. So likely that psychiatrists will start practicing using it in the coming days.
सर मैं पूछना चाहता हूँ कि फार्माकोलॉजी और साइकोलॉजी के कॉम्बिनेशन का जो रिजल्ट होता है वो सर tDCS और फार्माकोलॉजी के रिजल्ट से कुछ ऐसी थीसिस वगैरह है, कुछ ऐसी स्टडीज है कि जो कौन सा बेटर है?
It's a good idea for the new residents to opt for a thesis. So there are studies that compare tDCS versus pharmacotherapy, tDCS add-on to pharmacotherapy with pharmacotherapy alone. Limited number of studies are there with combining tDCS with psychotherapy, combining tDCS with pharmacotherapy, and looking for the outcomes. These are the areas where we can integrate multiple modalities of treatment together. In fact, I'll say that we used tDCS as a part of multimodal treatment in some of the patients. We published that as case reports, where we suppose a patient is having OCD. We tried with tDCS, we tried with exposure response prevention, we tried with pharmacotherapy. All the 3 things going concomitantly in a hospitalized patient. And those patients, they otherwise would not have responded to pharmacotherapy alone or past failed trials. They reported significant improvement in their symptoms. So multimodal treatment, more of a tailor-made customized treatment for the patient, will be definitely beneficial.
Thank you for the excellent presentation, sir. My question is, like Dr. Adarsh mentioned, we cannot monitor the process while it is being given, like ECG. So, can we have, are there a number of sessions we have to wait before declaring whether it is effective or not effective? Or do we continue through the whole protocol?
There are 2 types of devices. One type of device is mostly for delivering the therapy, clinical purpose. There are some devices, they are basically for research purposes. Those devices have additional features like real time during which you deliver the therapy, whether there is any brain changes are happening or not. At the same time, you are monitoring the EEG. Even you are quantifying the EEG, QEEG, you can monitor during delivering the therapy. So you can see the change in the brain across the sections. across the sessions. In the first session, the brain change was something. After 10 sessions, the change was something different. So those things will give you an idea whether actually tDCS is capable enough in bringing some electrophysiological changes in the brain or not. This is one thing. Second, those electrophysiological changes that are happening in the brain cannot be directly translated to clinical improvement. There are many studies, they reported that after sessions of tDCS, EEG changes happened in the brain from the baseline, but there is no clinical improvement. So something else is missing. We need to do further research to understand how and why brain is behaving in a very different way. Despite of change in the brain, functions are not improving.
But so
far, we need to
there are no side effects, it's better to
continue the sessions for at least 10 to 20 sessions before discarding it.
One more question you mentioned about accelerated protocols in tDCS is also used.
Yeah, accelerated protocol in TMS can be used, in tDCS can be used. In fact, there was a recently registered trial where they were using tDCS as a accelerated protocol 5 sessions in a day in the management of depression. 5 sessions in a day versus 1 session in a day. So you deliver 10 sessions over a period of 2 days. In other scenario, you deliver 10 sessions over a period of 2 weeks. Now you are comparing the efficacy and safety. Accelerated in terms of number of sessions you deliver in a day. If you give 1 session in a day, it's a conventional protocol. If you go for more than 2 sessions in a 2 or more than 2 sessions in a day, it is accelerated protocol. No. In theta burst stimulation also, accelerated refers to more number of theta. You have given 1 session, then followed by another session. So number of sessions in a given day is accelerated protocol. Extended protocol refers to when you go beyond the conventional protocol. Suppose majority of the protocol they recommend for 20 sessions, but you are giving 60 sessions. So you are going beyond the recommended duration of the number of sessions. So it is extended protocol.
Like MCA right now does not when we talk about tDCS and all. So in pediatric population, you have
FDA recommends for adult population. Whatever the existing RCTs or systematic reviews or meta-analysis are there, they absolutely establish that it is safe in pediatric population. One thing that is bothering is pediatric population, they are more likely to experience the local side effects. Local side effect like because the skin is soft and fragile, so we'll get burning sensation, pricking sensation, this type of things may happen in the small kids.
What we plan research, do we have to
adolescent population you can give, but for the very young children, one need to take due approval from the concerned regulatory authorities or use it.
Sir, I want to know from your experience on tDCS in patient with schizophrenia. Is there a subgroup of schizophrenia patient like those who have neuropsychiatric symptoms and those who have different symptoms? What is your experience?
Regarding schizophrenia, basically, if I talk about my own experience, we use auditory hallucination is the commonest target of management of schizophrenia. So there are options where you can use for cognitive stimulation where DLPFC can be targeted, cerebellum can be targeted. If you can target for negative symptoms, you can target the left DLPFC. Mostly we used high definition tDCS for targeting the left temporoparietal junction with cathode at the center and anode in a ring electrode. Or we in the conventional electrode placement, we put the cathode over the left DLPFC, cathode over the left temporoparietal junction and anode over the left DLPFC.
So I hope there are no more questions. So thank you, Dr. Sujit, for very interesting session.
Here we close the online sessions. Now we'll be moving to the hands-on training after the post-lunch session. So I just request all the participants to give their feedback. We'll be circulating the feedback form shortly after concluding the program, today's program. We have provided our email address. If anybody is willing to get any resource material, we are happy to share it. From my side, I personally want to thank Professor Renner for taking time on this Sunday, getting up early in the morning and joining the workshop. Thank you so much, Professor Renner.
Okay, thanks from our side, and I think it was a marvelous talk, and yeah, we're so proud to support you and in your endeavor, and I also hope that you're having a great afternoon. Thanks. Bye-bye.
Thank you. Bye-bye.
I close the session now and I end this recording. Bye-bye.
Thank you. Bye.